out for my YouTube channel and you'll likely see answers in the future. Or we've just answered them further down during this particular webinar training. So thank you very much, and I hope you enjoy. Today we're going to talk about how to grow your dental practice by helping more of the moderate to severe wear patients you may have been avoiding. And this webinar is going to be a clinical webinar, but it's going to help you with your practice growth as well. Because these kind of patients, there are a lot of these kind of patients in our practices and in our communities that really don't know that we can help them or know that we're the people to help them. So I want to help you help these people. And in the process, you're going to grow your dental practice. You're going to increase your production, your revenue, and your joy in doing this kind of dentistry. So I'm Dr. Stephen Phelan. If you haven't met me or seen one of my videos where I'm talking to the camera, this is me here. And this is my family, my wife Melissa, my son Jack, and my daughter Kylie. This is actually an older picture. Here we are now. And as you can see, the kids are growing up. My daughter's now a teenager, and my mom's with us. This was on the Disney cruise, and Chewie's with us. So we're Star Wars fans, and pretty much every year go on the Star Wars Day at Sea Disney cruise because it's just lots of fun if you're a Star Wars fan and you like Disney. So the kids really like both, so it's been good. At one point, the kids won't want a vacation with us anymore, but for now we're taking advantage of that being fun. The other thing that I like is I like to wake surf. So here's a picture of me wake surfing in the cold lake. This is a fall wake surf, so it's kind of colder, but wake surfing's fun no matter what. And I wake surf in October even, most years, which is in Ontario pretty cold. The lake's pretty cold. Usually the feet are getting pretty frozen. Here I was wearing these little booties, so my feet were warmer. But sometimes I forget and your feet are freezing. It's insane. The other thing that I really like is clinical dentistry, of course. And these are images from lower arch that I inserted yesterday. So I bonded this lower arch yesterday. It's part of a full mouth rehabilitation case I've been working on, part of an interdisciplinary case. The patient first had orthodontics. I referred her to an orthodontist. She completed orthodontics earlier this year, and we basically did the rehab. So we completed the rehab the way that I teach and the way that I complete rehabs, which is one arch at a time, after testing everything with the full mouth provisionals. So she was testing at this stage, the lower provisionals against the finished upper arch, and everything was good. So we completed the finished lower arch, and we bonded this in yesterday. Most of these are veneers, and there's actually a metal ceramic bridge here. She declined implant and went with the bridge, which she had a bridge that was 20 or 25 years old, so she just wanted to continue with that. And then these are zirconia crowns on this side, full contour zirconia, and then these are feldspathic layered ceramic veneers. And I bonded the veneers in with a new technique, which I'll share with my members, I believe, next month, because I videotaped the whole insert. I actually videotaped this entire case, essentially every step, because I got this new product, this new camera. It's called the Lux Cam, and it attaches to my loops. So I have a second set of loops that have this video camera attached, and it's allowed me to videotape pretty much everything. Some of the things I use the microscope for, and I've always had the ability to videotape with the microscope because we have a video camera on the microscope. But some things I still like to use my loops. They're 4.5 times Zeiss magnifying loops, so they're very detailed. But having the video camera now on this makes things really cool. So yesterday, we tried a new technique with bonding the lower veneers. I actually used rubber dam isolation for each veneer, and we bonded them in twos until we got to the incisors, and we basically had to bond them in individually. And I videotaped the whole thing, and I'm going to show it to the members next month. We have some great photos of how we seated the rubber dam on each tooth, and individualized isolation. It's I've done this rubber dam technique on a case last month, a different full mouth case last month, and I wanted to try it this month. And traditionally, I never would have done that. I would have bonded these in sections. So probably the 4 incisors first, and then cuspid, bicuspid, and then cuspid, bicuspid, bicuspid. So 4, then 2, then 3 likely would have been how I would have bonded it previously. But as I get older, I want just even more precision. And the rubber dam technique, I believe, offers me even more precision. Patient said she liked it because she didn't have to worry about keeping her tongue out of the way. I like it because it's just so precise and the tissue's completely retracted. We don't have to worry about bleeding, and I can precisely seat each restoration without having to worry about things moving. And for me, I like this. And I'm going to share this more and more as time goes on. And it's pretty common in Europe. It's not common at all in North America to see veneers bonded in under rubber dam isolation. I think it's relatively common in South America too. So certain parts of the world, they do this. And I have to say, I really like it. I videotaped the entire thing, also photographed it. I'll probably share it next month with my members. Now, if you have questions, I will do my best to answer as many questions as possible at the end of the webinar. So you could just type your questions in on the side. It's usually over on the right side here. Right side? Yeah, right side. Sorry, I'm left-handed. I get mixed up. And then disclosure, I have no financial interest in any of the companies whose products are mentioned in this presentation. It's not really a product-specific presentation anyway. I don't think there's much product in this at all, but, I will mention certain things that I'm using, and you can be assured that I'm just using them because those are what I like to use, and those are what I feel give me the best results, and I buy all of these myself. There's really not much that's given to me, even though I do speak and I do have members all over the world in my online course. I'm not out there looking to get free products. So I'm just looking to use the best products that I feel work the best in my practice. And tonight we're going to talk about, or today, depending on where you are, how to grow your dental practice by helping more of the moderate to severe wear patients you've been avoiding. And we all avoid certain patients in our practice. I did for sure when I was a younger dentist. And part of it was I just wasn't sure how to help these people. I didn't have a lot of confidence in systems that I had in my practice to be able to help them. So my first year I did veneer cases, but I didn't deal with the wear cases. And so it took time to develop the systems to be able to treat these cases. And also it takes time to develop the confidence to say, yeah, I can help you and I can do this and we'll deal with this. And if there's issues, I'll deal with that too. And these are just cases that I've been working on the last 4 months in my practice. This first case here is one that I'm sharing tonight. It's a new case. This is another case, partial rehab, not a full mouth rehab. This was also partial rehab, not a full mouth rehab. The rest are full mouth rehabs. This is a full mouth rehab I completed last month. Turned out pretty nice, overall quite nice. It would have been nice if she allowed us to alter the gingival levels on the upper arch, but she wasn't interested in the two things that would have been needed to do this, either pretty much osseous surgery for crown lengthening or orthodontic extrusion of the lateral incisor bridge abutment. So overall good result considering, we weren't able to alter the gingival levels. This case, pretty nice case. This was the case I did with the orthodontist. And she had periodontal issues to start with. She's an older lady, not really old, but just a little bit older. A little older than me, so not that old really. But she had some periodontal issues, so there was only so much we could do with the gingival levels. But it still turned out nice, and she's happy with it. Here she's in upper finished restorations against lower provisionals. So yesterday I inserted the lower final restorations, but I haven't imported the pictures yet, and she was frozen during the pictures anyway. Here's a case I started last month, which is a full mouth case. We're changing the occlusion design significantly and lengthening the teeth significantly. She started out with 7 millimeter incisors. We're now down to 10.5 millimeters. and we've lengthened the teeth significantly, but we've also improved overbite-overjet relationship, and she doesn't have the over 100% overbite that she had. So we've opened her vertical moderately. Here's another patient. This is actually a dentist I'm treating, and another full mouth rehab case. Nice before and after. I prepped this case a couple weeks ago. Nice patient to work on. Again, most dentists that I work on are really good patients, actually. They're appreciative of what we're doing. The only thing I look at when I look at the pictures now of this case is I think I'm going to shorten, if possible, the incisors, maybe even the one cuspid. I'm going to try and shorten the anterior a little bit. I find they're just looking a little too long. And I think we can do that and still maintain anterior coupling. We just might have to, which I don't think is a bad thing, we might have to make them slightly thicker facially. So some of the veneers are maybe a little thin anyway. Temporary. So being able to say, yes, I can help you. I can help these wear patients. I know what I'm doing, and I can get out of it if we have any issues, because not every case goes beautifully smooth when there's wear patients or occlusal dysfunction or bruxism. But we can manage it because we're changing and managing everything with the provisionals. So being able to say, yes, I can help you, can lead to a tremendous increase in production in your practice. And that's a good thing. That leads to great practice growth. And during this webinar today, I'm going to teach you where to start your analysis when a severe wear patient presents into your dental practice. So I'll share with you my system for this. I'm going to share with you some essentials from my system to identify the risks involved with wear patients. And there's risks for not treating them, and there's risks for treatment. There's risks that will happen because you're decided to treat this patient. And if you can identify that ahead of time and have a discussion with the patient about that, I think it's better to do at the beginning and not at the end or after something happens. And then how to design and test a new occlusion for these patients. And what happens here, this is critical, what happens if they cannot tolerate this new occlusion design? What do you do next? And that's really a big part of the fear that people have and the confidence that people need to develop if they're going to treat these kind of patients. What do you do if there's issues? And how do you know if there's issues? How do you manage issues? And then another big part to managing issues is how to manage the muscle forces with a wear patient, so you can improve and achieve longevity with the restorations. And then another really important area that I think I haven't talked about maybe enough in the past is how to choose the best restoration design for individual tooth in an erosion or attrition patient. And should we choose crowns, onlays, veneers, occlusal veneers, or veneer crowns? And I think you'll find this very interesting. And I'm going to show you the restorations, the preparations, plus the actual restorations for a case that uses kind of all of this. So it'll be interesting to see, because each tooth can be prepped, individualized for the best restoration design for that particular tooth, and it can all work within the context of an arch. So let's start with where to start your analysis when you have a severe wear patient. And really, I think everybody knows this, but maybe not all the nuances. And really, the bottom line is you have to start with the comprehensive diagnostic records. I've had wear patients come into my practice, and kind of the type that are kind of shopping around, and they come in, and I've had them come in with estimates from other offices. And they come in, and in the initial consultation, they ask me, well, I need you to give me an estimate so I can compare you essentially to this other office's estimate. Actually, one of the cases that I showed you in the 6 cases I'm working on currently, or recently completed, brought in a full written estimate from a different office. And they're basically saying, can you match this or do better? You know, they're price shopping you. And at a consultation appointment, before I've taken comprehensive diagnostic records, I refuse to give an estimate. I really do. I will sometimes give a ballpark if I'm worried that the patient has no clue what they're getting into. So I'll say, you know, these cases, when I treat these cases, They're typically running anywhere from 30,000 to, if you have implants involved in a full mouth rehab, it could be in the 70,000 range. So there's a big range. But if the patients come in for a consult and they're thinking about doing something fairly comprehensive, and $30,000 is so far outside of their ballpark that they can't even visualize it or imagine it, then it's good that we maybe don't go forward with records until they've reconciled that. So I will give a ballpark, but I won't get tied into an actual estimate because I haven't done the records. And so I explain to them, even if they bring in a previous person's estimate, that I need to do the records to figure this out. And it's the only way to do it because my diagnosis and treatment plan might be different than what they've brought in. So I've had a couple people, come in and ask me to do this estimate, and they have maybe a previous estimate from another person. And when I refuse to, without doing the records, they don't come back. And that's fine. I'm fine with that because it's kind of a line in the sand that I won't cross. But the lady that I showed you the pictures of a few minutes ago that went ahead with treatment, she did have an estimate from another office. It was quite a bit less too because they showed it to me. But, they went ahead with mine, I guess because of just the sequence that we go through, diagnosing, taking the records, and then treatment planning and presenting the case. I think that the system that we use is superior. And so that helped. But what you need to start with is the comprehensive diagnostic records. If you get anything out of this webinar today, I think the most important thing could be that, A, you need to do the records, do these diagnostic records before you give somebody who's walking around looking for estimates an estimate. Because you can't accurately estimate the case. And you can't build value for what you're doing without doing the records first and actually going through this with the patient. So we have a functional analysis system we follow in the practice. It includes a comprehensive examination, digital radiography. We are happy to use whatever old radiography they have if it's not too old. So if they have a Panorex that's a year old, I'm okay with that. I don't have to retake it. If they have some PAs that are a year old, if they're good quality, we'll go with that. Unless there's an issue, then we'll take new ones. So we don't have to retake all the radiographs, but we will retake some typically. And then digital photo series, we'll take a full digital photo series. And we're going to end up with CR-mounted study models that we can complete a model analysis on and then combine that with the digital photo series to complete risk assessment and then finish the treatment plan. The other thing that we could do today very easily, because our smartphones are so good with video, is we could complete a video analysis. I could use my scope for this, or I could use my iPhone for this, or I can use one of the other video cameras I have in the practice. But video analysis can be really helpful, and it's something I actually think I should do more of. I sometimes forget that, I should add a quick little video here for the patient when I'm doing the records. It's something that, you need to get into the habit of because it's so easy to do, and it can give you a lot of documented information to help with the case. So we have a series of documents we follow with our records. The first one is the functional analysis, and we're looking at, muscle, joint. We're looking for the PIC. We're testing and load testing, and we're ultimately creating 2 sets of CR-BITE records. So we want to have 2 separate CR-BITE records. I use the leaf gauge initially. So we take 2 CR-BITE records with the leaf gauge, 2 separate ones. We also create 2 sets of impressions. And you can do this in multiple ways. You can take alginate impressions. You could take PVS impressions. We typically take polyether impressions. So for the records, we typically will take Impergum. In some cases, we'll actually take Permidine. We can also scan the patient digitally. So we could take something like a Trios or an Itero. We can scan the patient, or the CareStream scanner. We can scan the patient, and we can even print models. And that can be done also. Ultimately, though, what I'd like to have is 2 sets of mounted models, whether they be printed models or stone models. I don't care. I'd still like to do the analysis of the case on mounted models on the articulator. And I'm okay if they're printed. That's okay, as long as they've been printed at high resolution. So we have 2 sets of CR byte records. So I don't mount 2 sets of models with 1 byte record. There's a reason for this. We use 2 sets of byte records. We complete a model analysis. And we also use the MPI, which is a mandibular position indicator, to double check the byte records and compare the CR position to the CO position. This gives us a lot of information. So here's the MPI. I actually have one in my office, and Harold, my main ceramist who does my rehab cases, has one in his lab. So we both have an MPI that we use for different things. And then ultimately we want 2 sets of study models. So we'd like 1 set made with 1 set of impressions, and unless they're printed, then it's just 2 printed sets of models from the same scan. But we also want 2 sets of CR byte records. So 1 set will be mounted with CR byte record number 1. The other set will be labeled CR byte record number 2. And then what we're looking for is, does the point of initial contact of the mouth, the patient's mouth, that we recorded during the records appointment match the mounting? So does this match the mounting? So you can see here, we have a CR point of initial contact on the mounting, and we have one that we recorded in the mouth at the functional analysis, and they match. So if they match, this is good. This gives us some verification that the case is mounted accurately, and you took accurate records, and the patient didn't have some kind of muscle issue that interfered with this, or you were just not accurate, or whatever the problem is. Because the thing is, these mounted models, whether they be printed or stone, are going to be the basis for building the case going forward. So they're going to help you determine the vertical dimension for wear patients of where you're going to build the case at, because most wear patients need the vertical dimension altered, and they're going to give you the foundation for your wax up. So here's the case we're looking at today. These are some nice mounted models. You can see she's closed on her mounted models to the PIC, the point of initial contact. And this is the space that we've created around the CR arc of closure. So this gives us space that then we can consider to use with altering the vertical dimension if we need to, because this is a wear patient. So here's the new patient's case, photos. So we look at our photo series. Here's the frontal view, lateral views. Patient has a lot of tooth wear, a lot of crowding as well, and that's going to complicate things. But a lot of tooth wear, you can see from these views, some serious arch form issues from the positioning of the teeth. That's going to complicate the aesthetics. And she appears to have lost vertical dimension and created a more end-to-end occlusion with her current position of where her teeth are. So this is a complicated problem to fix. You can look at it, lateral views, she's in a group function occlusion, significant amount of tooth wear, and some crowding. She said these teeth have been chipping and flaking apart. She had a piece of tooth come off and they bonded it. It's kind of uneven as far as the midline goes now, but that can be corrected. She's not as concerned about the lower incisors, even though they're crowded. They're the only teeth in her mouth that have very little erosion. You can see the erosive difference between the lower incisors on the facial and the cuspids and the bicuspids. It's pretty dramatic. Look at the erosion on the cuspids, and there's really hardly any erosion on the incisors. What would cause that? That's interesting. You can see the erosion on her occlusal surfaces and their palatal surfaces. And you can see there's no room for restorative material where she's closing to in her MI position. And there's no room to lengthen the teeth where they're chipped and to fix this in this current occlusion. So another view of the erosion, pretty significant erosion. On the upper arch, it's most significant from first bicuspid to first bicuspid. It's moderately significant on the second bicuspids and not as nearly as significant on the molars. Here's a Panorex view. Good news is she has great bone. She's only in her 30s, I believe, at this time. And she has great bone. So bone is good. That's one less problem to deal with. So as I said, this is erosion, and it's what I would consider severe erosion. I've seen worse, actually, on a few patients that we've treated. But it's pretty severe for somebody in their 30s. It's moderately significant. And it's causing her, some occlusal issues, aesthetic issues. And at this point in time, she's coming to see us because now she's starting to have pain. So all of this exposed dentin is starting to hurt. It's affecting her ability to eat. And she says it's significantly starting to affect her ability to eat the last couple of years. Wasn't so bad for a long time, but last few years, it's significantly affecting her. So what would you say is the source of this kind of erosion? What do you think is the source with this kind of erosion? I'm wondering what everybody thinks. Sorry, when I click out, it's kind of crazy. It kicks me out of Keynote, which is really odd. Here we go. So source, we've got a couple of comments, and we have an overwhelmingly same comment from everybody, which is interesting. And it does look like what the comments are. So I agree. This is a good diagnosis. So the common comment is that people are saying this is acid coming from inside the body, outside the body. And that's a good diagnosis. Acid reflux, GERD, hernia, bulimia, yeah, that makes sense. All of these make sense, but that's not what this is. This is actually something different. And the source of this erosion is Coca-Cola. So this patient was drinking, one of these 2-liter bottles of Coke like every other day, like totally drinking way too much Coke, which is very acidic. And, bulimia does look like this. This upper arch looks exactly like that. Very common. But you don't tend to see it on the facial of lower cuspids and bicuspids like you do here. So this is actually Coke drinking. Coca-Cola, just way too much Coca-Cola. And I've had a few of these over the years. Actually, there's another case in this presentation where it's probably the most severe Coca-Cola erosion I've seen in my career. And he was drinking, he claimed, a 2-liter bottle a day or a 1.5-liter bottle a day. Coca-Cola in high numbers, high levels of intake is basically keeping your teeth sitting in acid. So acid reflux, bulimia were all good answers, but her diagnosis was excessive Coca-Cola drinking. It really was. And she recognized this and recognized that getting this corrected involves cold turkey on the Coca-Cola. So that was part of our discussion when we were treatment planning the case. And so she has far more erosion than attrition. Erosion, looks like all of this. The facial erosion, the palatal erosion, the occlusal erosion. Attrition looks differently because it's more flat, smooth, worn surfaces. This is, there's a lot of ragged enamel in here that you wouldn't see if there was more attrition than erosion. This patient probably has some attrition as well, just because her teeth are now end-to-end. Once everything collapsed and her teeth became more end-to-end, all these thin edges started breaking because of the position. But she doesn't have as much attrition as erosion. It's more erosion than attrition. If you look at this case, this is a little video clip I did of a severe attrition patient. This is severe attrition. You can see we've worn down to really flat, smooth facets. And there's no little cupping areas like you'd see with erosion. It's all smooth, worn right down. So you can see no cupping, just flat, smooth and worn. So this patient probably has some erosion also, but it's more attrition than erosion. So it's primarily attrition with secondary erosion because there's so much dentin now exposed. And this is what somebody with severe attrition, usually bruxism, does to their restorative dentistry. You know, this patient came in like, look at that bridge, it's destroyed. This is destroyed restorative dentistry. Even that crown is damaged, and this crown here broke, and destroyed restorative dentistry. So that's more attrition than erosion. The patient from the case study tonight is more erosion than attrition, which if I had to pick one or the other, I would pick erosion over attrition because generally that patient I'm treating that I'm showing tonight is not likely a bruxism patient. She's more erosive with parafunction. That's how her chipping and wear became developing on the front of the teeth, the front teeth. But the other patient, the patient in the video that I just showed you, this patient's bruxism with secondary erosion. So that's more dangerous for us to manage. And you saw what he did to his old bridge. So what we want to do is create an occlusion design that will improve the force management for your wear patients. So we want to improve their ability for their restorations and their design of their occlusion to withstand the forces that they will put on it. So the current occlusion for the patient with the erosion, I can't build her in that current occlusion at that vertical position. I just can't build the restorations. There's no room. There's no room. And she's got severe erosion on the palatal of her upper incisors, so there's no space. So we have to change the occlusion to build and help this patient. And we want to help the patient. We want to improve her aesthetics too. So we have to change the occlusion. And either we're going to open the vertical or we're going to do fairly comprehensive orthodontics. So the case study patient that I'm showing you tonight, we completed the functional analysis for this patient. And for this patient, we had a problem. We had an issue with the functional analysis. And there's probably a few reasons why we could have had a problem with it. One is that number one models, the PIC, the point of initial contact, was 1.7 that we measured in her mouth, and we found it on the model. So 1.7 is the upper right second molar for those of you from the United States. So we have a PIC here, upper right second molar, or 4.7, which is lower right second molar. So this is what we found, and this looks good. So this we think appears to be accurate. But the second set of models with the second bite record, we found the point of initial contact on 1.6, which is the upper first molar on the right side, against the lower first molar on the right side, 4.6. And it does not match the functional analysis or model set number one. So we have a discrepancy. And we have a significant difference in the vertical dimension at the PIC. Significant. Like this is a big change. So what do? Are we going to pick one of these and go with that to make the wax up? I don't think so. It doesn't make sense. We could hedge our bets and say, oh, well, 1.7 is right. This set of models is right. Let's just go with this. But I don't know that. This looks like there's lots of space, but it doesn't appear to be matching what we found in the mouth. Now, the issue with a case like this, a lot of the time, is this case has some significant erosion. There's a lot of little potholes and little erosive holes and little divots and depressions around even the posterior restorations. This is a very hard case to get good, accurate models on. So that might have been one problem. You look at, we have two sets of CR mountings that do not match. Is one mounting correct and the other not? Why would this be? Well, it could be that one CR byte record is correct and the other is not. Typically, though, typically we wouldn't have that because we're taking them at the same time with the same technique. Usually they're the same. But it could be that they're different. And we could check that on the MPI. Could be that both the CR byte records are inaccurate. So both are wrong. That's possible. Could be that one of the sets of models is distorted. It could be that both of those models are distorted. Both sets of these models are distorted. So neither of these is actually the right vertical dimension at the PIC. So these are a lot of things. It could be that one or more mountings was just done incorrectly. So models weren't seated properly in the byte record. Byte record maybe wasn't trimmed properly. So there's a lot of variables when you're doing these cases about what could be wrong when you don't have matching byte records that match the findings in the functional analysis. And that's a problem. Now, the good news is, following the system that I follow, the majority of the cases, the byte records match. But it's not always the case. Even the dentist that I showed you earlier that I was treating, her byte records didn't match. Or her mountings didn't match. So in cases where the mountings don't match, the solution is really to take two new sets of byte records and two new sets of models. And in this case, I noticed also she had a tendency to posture in a forward position. It was actually to try and hide the fact that her front upper teeth were really worn down. So with this in mind, I decided we would deprogram her. So there's multiple ways you can deprogram a patient. One nice way is just with a simple Coy's deprogrammer. So I decided we would deprogram the patient for 2 weeks and then take new model impressions, try and get them more accurate by taking them with Permidine. The original ones were taken with Impergum, and Impergum's good and it's generally accurate enough, but with all the little indentations and things in her occlusal anatomy, we decided we'd go with Permidine because I think that the Permidine light body flows better into little areas like that. So we decided to change everything. We're going to take two new CR byte records after deprogramming with the deprogrammer, and we're going to also take the models with a Permidine impression. And I'm going to have Harold pour the models because he's probably the best model pouring person that I know. And these are tricky, difficult models to pour. So we didn't even want to pour them in our practice. So Harold was going to do all the heavy lifting here after I took the records. And so Coy's deprogrammer looks like this, if you're not familiar with it. And it has an anterior stop, and the patient can wear it through the day. They can wear it at night. This is actually a different patient, not our erosion patient. Patient here has some nice old onlays. These are 20-something-year-old onlays. These two here are, I believe they're 21 years old. And these three here, inlays and onlays, I believe are 18 years old. So it looks like these ones fit better than these ones, or maybe just the cement was a different cement. I'd have to look up what was what, but they're doing pretty good for the age that they are. But this patient went through an occlusal muscle issue problem at one point, I think due to stress, and we deprogrammed her and it seemed to help. So this particular patient that I'm showing you tonight, we decided 2 weeks of deprogramming should be enough. And if I bring the patient back and they're when I ask them to close, they're always going to the same place on the deprogrammer, and they've been wearing the deprogrammer a couple hours before they come in that day, then I think we're good to take the byte record. Sometimes they come in and we ask them to bite down on the deprogrammer and they slide around still. And I try to mark the contact that they're biting into, and it's variable. Those patients I feel aren't deprogrammed enough, and I deprogram them a couple more weeks. Most patients, 2 weeks is enough if they've been wearing it, and we're good. We can go ahead with the byte records. So this patient, she was fine. I'm going to show you a little video taking the byte record with the deprogrammer, and then once again trying to locate the PIC. So I'll let this play. It does have some audio.
And bite down.
At this point, you can see how she bit down, didn't slide, didn't go anywhere, so she's nicely deprogrammed. At this point in the video, I've already taken bite record number 1. So I'm now taking bite record number 2. I didn't think you had to see both. In this particular video, I actually edited this video down from the one that I showed my members because it was too long. Good. I think I will show you her biting down again though, because this is what you want to see with deprogrammed patients.
Down.
Just good. See how she bit down, just went right straight into the deprogrammed spot and was not sliding around. That's what I like to see.
So I think we'll do a leaf gauge next, and the leaf gauge will check for the PIC. Okie doke. Could you let me know what the PIC was last time?
I think there was a bunch of them.
Yeah, I think there was 2. I believe there was one first, though.
No, there's only one. 4-7 distal on the window.
Okay, so we'll see if that's the same. 4-7 distal. Open for me. Bite down again. So bite down. When you're biting down, how does it feel? Is it even? Yeah, it's even. So do you feel it touching anywhere before the other area when you're just biting like that? You don't feel it touching, say, here first, or so it's even across. Okay, perfect. Open. That's what we want. Let me see. Bite down again.
So if you notice, she's biting vertically, everything feels even, there's no low tension or tenderness, and she's biting in the same place. She's actually worn a little notch into the deprogrammer ramp of the spot that she likes to go once she's deprogrammed, and we marked it with articulating paper, and I could visualize with the mirror that she's gone back to that spot. So after 2 weeks, they'll typically mark, because it's not really hard plastic, they'll mark the spot that they like to sit in. And that's what's been done, and that's what we look to see. Now, if she had bitten down one time here and one time forward of this, you know, I would feel that she's probably not deprogrammed, and again, these records shouldn't be taken at that time.
Okay, open. Let me take a picture of that. Okay, so we'll leave those on. For now, I'll take the leaf gauge. And how many leaves was it? Right down on this. Go forward. So go forward a little, go back all the way. Do you feel anything touching at the back? Not right now, huh? Open.
7.
Right down. All the way back. And open. And just stay open for a sec. Can you put 7 in? We'll check it again. Maybe put 8. We'll see what it is with 8.
So we had recorded in the functional analysis document the PIC that we had at the previous records appointment, and we also recorded the number of leaves. So I thought I'll check with one additional leaf and see if now that she's deprogrammed, she's contacting with that, because I want to see the point of initial contact with the most leaves in place. So with the leaf gauge, we can vary it. So last time it was 7. I'll just check it with 8. If she's not touching with 8, we'll take it back to 7. And we want to see if it's the same as what it was when she was deprogrammed previously, or when we took the initial bite records without deprogramming. Because maybe it is, maybe it isn't. We don't know.
Bite down, go back all the way. Do you feel it touching now? Over here or over here? Just when you're back all the way, not when you're kind of going forward. Nothing touching? Okay.
So with 8, she was moving all over to see if she could pick up a contact, and she didn't feel any. It's amazing that one leaf will make that much of a difference, but it does. So we try and dial around the leaves to find out which one is the actual point of initial contact. opening, and that appeared to be 7.
Open. What about now? So you feel it touching? And it's over here again? Okay, let's check.
I think so.
Yeah, we can check. So it seems like it's the same as before.
So to check this, I actually use 8 micron shim stock. It's the best way because you'll see when I put in the articulating paper, I actually get false positives all over the place, even with really thin articulating paper like AccuFilm. But the shim stock doesn't give you a false positive. It either holds the shim stock or it doesn't. The challenge is getting the shim stock at the back of the mouth without folding or moving, and you'll see what I mean. It's a little bit of a challenge, but we can work through that.
Open for me. Bite down all the way. Open. Bite down all the way. Open. Bite down all the way. It was 4-7?
Yeah.
Open. Bite down all the way. Open. Bite down all the way. Open. And the lingual.
Yeah.
Bite down.
Just along the lingual, yeah.
Open. Touch and hold. Bite down. All the way back. There we go.
Yeah.
Open. Bite down all the way back. Yeah. I'm doing it there. Okay. Just open. All the way back. Bite down and go all the way back. Okay. I'm getting it there. Open. Bite down, go all the way back. Open. Bite down. So go all the way back. Okay. Open. Bite down.
So the left side didn't hold even articulating paper, let alone shim stock, but the right side does hold articulating paper. It's not really, I'm having a hard time getting the shim stock to stay on the distal of the last molar. So I decided to test at least seeing where the contacts looked like they were with the articulating paper, and then try and identify them better with the shim stock. So that's what we're doing here.
Okay. Open. Bite down. Go all the way back. Now we're going to bite this way too. Open. Bite down. All the way back. Yeah, open. Bite down. All the way back. Open. Bite down. All the way back. Open. Bite down. All the way back. Open. Bite down all the way back. Yeah, without it on the bi also. Let me look at them here.
So you can see this shim stock tore on the bicuspid, the second bicuspid. It also tore, I don't know if you noticed, on the second molar, but it pulled right through the 6. And the first molar, the 6, 4-6 we call it, lower right first molar, it actually pulled right through, and there's a big articulating mark there. So if you had just gone with articulating marks as your indication, you might have thought the PIC is actually 4-6.
Oh, can I get a mirror that's
Not scratched.
Hi.
She wants the shim stock out of her mouth, obviously.
Sorry.
So the upper first molar, right first molar, has a huge mark, but that's actually not holding shim stock. The second molar is holding shim stock, the second bicuspid is.
Yeah, big false positive on the 6.
And look at the just all the little dips and depressions and erosion on the surface of these teeth. You know, it's no wonder the models are hard to get accurate. They're hard to print too, especially this distal of the 7. There's such a thin little area there. Hard to print, hard to pour.
So it looks like it's 4-5 buckle. And then 4-7. Let's just see if this one's touching. Bite down. Oh.
I'm still not sure about that 4-6. Oh, sorry. So I was actually checking it again, the 4.6. Let me go back to that spot. Yeah, here we are.
Okay, so it looks like it's 4.5 buckle. Let's just see if this one's touching. Bite down. Oh, fell out. Bite down and go back all the way and clench. Seems like a false negative open. False positive, I mean. Bite down again, all the way back. That one isn't open.
Yeah, so there it is. You know, the shim stock gives me the ultimate ability to identify the PIC. So we've identified that. We can tell Harold we're going to send him the bite records. Here are the bite records, or one set of the bite records. Here's a close-up of that deprogrammer, and here's the spot she was stopping on. So you can see she does have some movement around on the deprogrammer. So, you know, is she dysfunction or is she parafunction? Not totally sure. My guess is she was dysfunction, but, you know, we won't be able to tell for sure if she's parafunction until we actually test for that. So initial CR with the leaf gauge, we found it to be on 1.7, which is the upper right second molar. New CR with the deprogrammer, we also found it to be on the upper right second molar. We also found a spot on the upper right second bicuspid, and you can see it was marking, and we found it on the initial records too. Again, all of these little, like even this spot on the bicuspid, it's this raised elevated area in around an erosive area. You know, this makes, again, the accuracy of your mounting so much harder because of the difficulty in creating accurate study models from this type of dentition. But the bottom line is the PIC matched the functional analysis with both times we did the records. So here's the close-up again. As long as we can get well-poured models, I feel that we should be able to get a good recording of the patient's situation on the articulator. So I believe what happened in this case is, I don't think maybe that the bite records were incorrect the first time. I think it was the models were distorted. And I think it might even have been both sets of models were distorted. And what we had happened, we went back and looked at it, and the models actually didn't look very good. And what we realized was, Amanda let me know afterwards that we had a temp in for a week or so around that time. I think one of our assistants was on vacation. We had a temp in, and the temp actually poured the models, which was really a bad idea. And you can see the porosity in the models. The models are not good. So maybe we didn't have to deprogram the patient. I don't think it's a bad thing to deprogram the patient, but maybe we just needed the same bite records with better models. I'm not sure now. But I think that deprogramming her wasn't a bad idea. But the biggest problem was the models. So you can see these models, and you can see how she's posturing forward. This is protrusively a little bit more than her occlusion. And you can see how she was holding her teeth forward like this to try to mimic, hide the fact that these teeth had become so short. And she told me this. And that could be part of the reason for some of the tooth wear in an attrition motion. So I felt she was likely parafunction, not bruxism. So how do you identify the risks involved with your wear patients? Both the risks of treatment and the risks of doing nothing. Well, the risks of doing nothing, obviously, especially for a patient like this, with this much erosion, is that it's going to get worse and worse and worse. Once you have so much exposed dentin, everything gets worse. There's more and more erosion and wear. Even cutting out the Coca-Cola habit, she's still going to have more erosion continue because of all the exposed dentin. And her occlusion will continue to collapse. And it tends to, as these teeth get thinner and the contacts wear, the teeth tend to retract palatally, the upper incisors, and the patient becomes more and more and more end-to-end. And that leads to more and more wear. So it's a pretty vicious cycle. So intervention at this stage, or ideally even before that stage, is needed. So intervention is needed. So there's a big risk of not doing anything, is that she's going to start breaking teeth even worse, and she'll end up edentulous. So what we want to look at is risk assessment, and the factors influencing treatment outcomes are really fourfold. There's the patient, the clinician, the biomaterials we use, and the treatment approach that we use. And really, 3 of these are in our control, and we can influence. 1 of these we can't influence. It's not within our control. Not really. You know, we could try and influence behavior, and we could try and influence something like drinking Coke all the time. And the patient, you know, typically if they realize that that's what led to the problem, and they've made the step to go forward and have treatment, they'll manage the problem themselves. But, you know, I believe that the patient has the dominant influence on our treatment outcomes. If this patient that I'm working on tonight was a bruxism patient, that's going to have a big risk effect on my outcome. If she continues to ingest a lot of Coke, like a bottle of Coke a day, that's going to have a negative influence on our outcome. All of the things that the patient does will have the biggest negative influence and create the most risk to our outcomes. Assuming, you know, we have pretty competent skills, we use good biomaterials, and we use a reasonable treatment approach. Obviously, if we don't have these 3 yellow circles in order, that'll present problems for the case survival and predictability. But assuming you have all 3 things in order, the biggest risk factor is the patient, what they're going to do with their teeth. And I think that this knowledge can be a little liberating, because most of the patients that have issues post-treatment are not because of our skills, our biomaterials, or our treatment approach. Most of the issues are because of preconditions that are risk factors that the patient presented with in the first place. So it's helpful to identify these risk factors beforehand and to develop an individual risk profile before you even start treatment, because this leads to a more meaningful discussion with the patient about what risks are involved and what issues are involved with the case. So you look at risk assessment. I've created a document for this. I actually have multiple versions. We're on our latest version now. We're actually going to give you a download at the end of the webinar. So if you stay on the webinar until the question and answer time, we're going to put up a download link for my risk assessment for complex cases PDF, and also something that I've never given out, my occlusion design force management checklist. So my force management checklist, which we will look at today. So the inspiration for this risk assessment document came from the ITI. So I went to a course in the University of Bern, aesthetic implant course was one of them. And they kept looking at the cases from an aesthetic risk factor perspective and from a risk assessment perspective. And I thought that was really cool for thinking about implant cases. And Dr. Boozer was putting up these slides with risk factors and then low, medium, high. And I thought, I really like this. I'm going to develop a system, a risk factor system for restorative dentistry for complex cases. And that's where that came from. That's where this document has come from. And it's basically the same idea as the ITI has for aesthetic risk factors for implant dentistry. And then Dr. Coy has also influenced this because he has kind of a risk profile that he talks about with treating patients. So mine's slightly different because it's kind of a risk assessment with low, medium, and high. But Dr. Coy's has similar ideas. And if you have a chance, I recommend the University of Bern with Dr. Boozer, Daniel Boozer, for implant training. It's fantastic. It's a neat city, University of Bern. I should have put up some pictures. It's a neat city to go to. It's a little old European kind of medieval city. You basically, well, for me, I flew into Zurich and then took the train to Bern, and you're right there. So that I recommend, and obviously I recommend the Coy Center. It's fantastic. I did the Coy Center programs as a young dentist back in the 90s when it was really small. It wasn't at the current location. It was in the back of his office in near Tacoma, kind of in the boonies. But it was great because it was yourself and 11 other dentists with Dr. Coy. So it was a very small group. But you look at risk factors. We've made a slide for this as well. And for this patient, I assessed this as the risk assessment. So I looked at the risk assessment for this patient, and this is what I came up with. And I'll show you that in a minute. But really, I thought that 8 out of 15 are high risk, which is fairly high risk, especially considering some of the 8. And so you look at her dentition, and really it came down for me that 8 out of 15 are high risk. And there's no room for restorative material, so this leads to high risk as well, obviously. So once again, 8 out of 15 are high risk. And the patient starts with these risk factors. And 8 out of 15 or 9 out of 15 or 12 out of 15 that are high risk. And what you have to do is, to the best of your ability with the case and the treatment plan and the treatment, you have to manage the risk factors to decrease high risk and try and move some of these high risk down to medium or low risk with the treatment approach that you're using. But some of them, they cannot be decreased from high risk. They're always going to be high risk. And that's just a fact of life. So you can attempt to risk some of these high risk factors, reduce them with your treatment plan, your occlusion design, your aesthetic design, but you can't always eliminate. So if you were to think from that perspective, the patient's aesthetic expectations, most of the cases, patients that come to see me, their cases are high risk because they have high expectations. Now, I decrease that risk by using a really elite ceramist, so that helps. And figuring out the aesthetic design with the plastic provisionals or with a mock-up, so that helps. But, there's going to be some risk involved. This patient, the smile line was about medium, so it wasn't so risky. Periodontal status was healthy. Gingival levels and biotype, it was actually somewhat uneven from lateral to lateral, pretty uneven. So that could be high risk. You can either decrease that risk by osseous surgery, or you could decrease that risk by having the discussion with the patient that, we can either change this or you can live with it. But if you live with it, you've decided that. That's your decision. And she decided, if you can change it slightly with gingival surgery, I'm cool with that, but I'm not going to go with osseous surgery. And the other thing for this patient was she didn't want orthodontics. She said she can't imagine going on 2 more years with the amount of discomfort she has because the teeth have so much erosion. And she just doesn't want orthodontics. Some people, they don't want orthodontics. And, we have the discussion then that I probably can't fix your lower incisors without ortho. It's just not going to happen. And she said, I'm not worried about that. And so we decided we'd leave the lower incisors because there was no ortho in the treatment plan. So uneven levels in biotype, it was more uneven levels. She has reasonably good biotype. So we decreased that risk factor by just basically having a discussion about it. Biomechanics, she has 2 structurally compromised teeth from endodontic treatment, and she has some significantly structurally compromised teeth from tooth erosion. We can't really decrease that risk factor. That's going to be with her the rest of her life because of the condition that she's become. So that's one that's always going to be high risk. Tooth alignment, we can reduce the risk by having orthodontics. But if she doesn't, accept that, then we have a tooth alignment problem that can't be changed. We have to have the discussion that this is the way it's going to end up. And she was okay with the incisors staying the way they were. TMJ and muscles, in this case, it was good. She had no load testing, and she had normal range of motion. So that was good. Bite force was high. We tested her masseter muscles. They were large, and she has high bite force. Tooth wear, she has significant erosion, so that's high risk. Chewing pattern, she appears to go front to back and side to side. She appears to go in all directions, so that's higher risk. Guidance pattern, she has group function, that's higher risk. We can decrease that by creating an anterior guidance with her new occlusion, so that's good. Occlusion design, she's currently end-to-end. End-to-end, because of just the collapsing of the vertical and the tooth wear. We can redesign that to have better overbite overjet relationship with the new occlusion, so that's not so bad. Occlusal planes, they're relatively level. It's maybe slightly low on the right side, but overall not a big risk factor. Occlusal disease is interesting because you could make the argument that this patient might be bruxism, and she might be bruxism. My thought was that she was occlusal dysfunction or parafunction because she was posturing forward, and I felt that she was doing this to try and hide the looks of her teeth. And it wasn't parafunctional, it was more habitual, which would resolve after she's happy with her teeth. And one way to test that is to see what happens with the provisionals. You could also make a splint, see what happens with the splint. There's some other types of bruxism testing that you could do, but the bottom line is I felt that this was parafunction or occlusal dysfunction. You could also ask about sleep apnea. I'll tell you, a lot of the wear patients that I show have sleep apnea and actually are on CPAPs. This lady didn't have sleep apnea, is not using a CPAP, but a lot of the older adult males, almost all of them, the wear patients that I show are sleep apnea patients, and they already have a CPAP. So we seem to have good medical diagnostics here in Ontario, and a lot of patients are very aware of this, and they seem to be getting treated and diagnosed, so that's good. Decreasing risk factors for younger patients that show wear at an early age, in their early 20s or even their late and mid-teens. We recommend bite splints, and usually just a simple CR splint that covers one arch, because what they'll do then is they're just going to wear the splint. So instead of wearing their teeth, they'll wear the splint. They'll cause marks in the splint. We'll be able to tell that, yes, they're bruxing, but they're damaging the splint, not their adjacent teeth. So we're pretty good advocates of bite splints for patients that exhibit any kind of tooth wear at a young age. If they continue to have, this kind of wear on their splint, we're going to basically encourage them to continue to wear them. We could look at, and we do this in some cases, we could look at equilibrating the patient and some minor composite bonding to improve the occlusion. But some patients, we just go right to the splint. So it varies. But I think if you can identify the young people with wear and manage them at a young age, you can prevent a lot of these people from getting to this stage. So I only saw this patient the first time when she came into my office for records, for a consult first, and then followed by records of what you see here. So we weren't able to help her at a younger age, but she's been developing that amount of erosion for probably 20 years. So if somebody caught her at a younger age, had the discussion about the acid, and had a bite splint created for her, once she started having tooth wear, she may have been able to be prevented from getting to the stage that she did get to. So how to design and test a new occlusion for these patients? What happens if they cannot tolerate this new occlusion design? And that's a big one. That's a big one why people have confidence issues going ahead with these cases. Do I know that I've designed the right occlusion for my patient? And what can I do to get out of it if I find that I didn't? And these are big questions. So what we're going to do is talk first about designing the new occlusion. Once again, we're going to attempt with the new occlusion to decrease risk wherever possible. So we have a patient here with no space for restorative material. So for me, the obvious thing is we either have to do fairly comprehensive, extensive orthodontics, or we have to open the vertical dimension restoratively. Because she needs restorations, it makes sense to open the vertical dimension restoratively. Does this have to be a full mouth rehabilitation? It could be, but I don't know that it has to be. And she has so much crowding on the lower four incisors, I'd rather just leave them alone. They're not eroded. I'd rather focus on the rest of the dentition. But do I have to restore every tooth in the mouth with porcelain other than the four incisors? I came to the conclusion that I didn't. So I felt that I could leave the upper first and second molars and do some composite bonding for them. And I felt that that would work. So the expression of your treatment plan and your new occlusion design and your new aesthetic design is created with the diagnostic wax up. And we are still using wax for a wax up on models. And I think we're going to continue to do this for a while yet, especially with full mouth cases. We may do digital wax ups with maybe a veneer case where we don't have to change the occlusion significantly. But a case like this where we're changing the occlusion significantly, I'd like to see it on the mounted models on the articulator. So as we talked about, we took new bite records at the deprogrammer appointment, the Quay's deprogrammer appointment, and we took new improgum impressions. And in fact, I took 2 upper improgum impressions because one I was worried might have had a void, well, just an area that wasn't quite right. And we took 1 lower. And if you look at the impressions, they have so many different little topography indentations and changes. You know, you need a very accurate impression material for a case like this. We actually also scanned her with the Carestream scanner and printed models, but they weren't able to handle quite the level of topography change that was present in this case. Even with, we used a $80,000 printer and printed at highest resolution, and it still wasn't quite as good as the Permadine poured study models poured by Harold with vacuum mixed dye stone. So these impressions poured with vacuum mixed dye stone mounted with these bite records gave us the most accurate representation of the patient. Now, if you have a patient with normalized anatomy that doesn't have this much erosion and all these little thin areas, printed models might work just fine. I think they probably will. But a case like this is ultimately what we had to go to. So I sent Harold all of this, plus a lower mounted model, because we already had mounted models for the patient, so I didn't feel we needed to send a new face bow. We just cross-mounted to the previous mounted models, which had the correct face bow position. They were just, I believe, not perfectly poured. We could have sent a new face bow also. I actually don't like shipping the face bow transfer because I worry it's going to bend. So because we didn't mount any of the models, we didn't mount the model on the articulator, so I sent a cross-mounting model. The bottom line, though, is we sent all of that, plus this diagnostic records instructions, plus some printed photos, and plus emailed the photo series. So all of this allows us to communicate with Harold exactly what we would like for the new aesthetic and occlusion design. Patient had a smile design from my collection of smile designs that she liked. We just wanted it rounded slightly more than that smile design. So it was this one, but we wanted even more roundness. We liked this tooth arrangement. We just wanted them more round than this. And then we decided we would treat, it ended up being 7. We thought maybe 7 bonded restorations, 16. As we were doing the wax up, Harold and I discussed actually adding 2 extra porcelain restorations. Originally, I was thinking I could bond the lower second molars as well, but we decided they would be best suited with full coverage porcelain. So we would bond the upper 4 molars. So I was bonding 4 upper teeth. Oh, actually, no, 6 upper teeth, sorry, because I bonded the upper second bicuspids also. So we did 8 upper porcelain restorations. That's what I decided we needed to do on the upper. And then on the lower, we ended up deciding on 10 lower porcelain restorations. So you'll see as you see the case. And I did my own version of DSD with the Apple Pencil and drew the smile design that we felt we wanted. And then the important photos here are the arch forms. So I'm showing Harold here. The arch form is really not good on the upper arch, but the good news is we could build the upper arch out because there's a lot of facial erosion. So the idea here is building the arch form out so I don't have to prep the teeth as aggressively. And that's where we're showing here on these 2 photos. And I'm going to have to prep in a little bit on one lateral and one central, a little bit on the distal corner of the central, the mesial corner of the lateral, because I didn't feel we'd build the arch form out that far. But everywhere else, you can see how these are sticking out. Everywhere else we're building out. So we're going to bring in 2 spots, build out the rest. And that's the way I think about a lot of these cases where there's crowding that we're correcting with porcelain restorations. We want to build out the arch form so there's less grinding needed and more conservative restorations and preparations. So we did note during the records that we had PIC on 1.5 and 1.7, which is upper right first molar, second molar, and upper right second bicuspid. No PIC on the first molar. And so I wanted Harold to check the mountings against that. You can see my Apple Pencil smile design, my APSD, not DSD. I should brand that. APSD. So I did this just drawing with my Apple Pencil. You can see the close-ups here. I drew this. I showed the patient we're going to shorten to laterals a little bit because there's a lot of chipping on this one. And it's got some sharp edges that would maybe damage the upper porcelain eventually. And I kind of showed her where we're building up the teeth and building out the teeth. So it gives her an idea of what we're doing. Now, when I did this initially, I looked, okay, I've got the midline wrong because this bonding has been overdone and it's making one central wider than the other. So we just corrected this with a different line. So I wanted her to see that we're going to fix the midline with this. And you could do this on, well, it used to be you could only do it on the iPad Pro, use the Apple Pencil. Now all the iPads you can use the Apple Pencil. I like the large iPad Pro because it's nice to draw on. I think it's 13 inches. It's huge. It's a huge tablet. And now the new Apple Pencil and the new iPad, even the regular, you could draw with the Apple Pencil. So APSD can work really well. The other thing we use in practice is we use my Smile books. So I've created a series of books. This is my porcelain veneer book. And we have some of my favorite Smile designs in the porcelain veneer book. And I use these to help with Smile design when picking smiles. And this is the new version. The old one didn't actually have this case. So the new one, I've added this case, the case that I'm showing you tonight, because it's one of my favorite new cases from the last few years. So I've added this so that other patients can look at it and say, yeah, I would like that Smile design also. I love the shape of these teeth. And so another view of some of the inside pages from the book. Again, I use this to help patients visualize what we can do. It increases case acceptance. It helps with informed consent because I show some prep photos, show the provisionals, and it helps just with Smile design because I have a few different Smile designs that I feel are some of my best that we've done together, Harold and I. And then second page, we have detailed tooth position. I'm asking for the incisors to be 10 to 10.5, 8 to 8.5 wide. We're giving exact positions for lengthening and labially positioning the teeth. We have to lingually position those two areas I showed, and I said to see attached photos, just showing where I'd like the arch form to be built to. And then on the lower, I'm gonna lengthen some of the teeth. I'm shortening those two laterals, and I'm labially positioning the cuspids and bicuspids because they were eroded facially and they need to be built out. So once again, I asked him to look at the photos to see this. And then the gingival levels I said were acceptable. I did say I would maybe do a slight adjustment I told Harold I might do a slight adjustment to the one lateral once I froze her, depending on where the gingival level is relative to sounding to the osseous crest. And I also noted that the midline is off and needs to be reshaped with the provisionals. And then occlusal function. I made the note as discussed, if you can pour the models, use the previous mounted model for face bow position and pour both two sets of models from the impressions and mount both sets on the articulator with the 2 bite records. And then based on the initial bite models, I said, I think we may need to open beyond the PIC, but not totally sure until I see the mounted models that you pour up from the new, more accurate impressions. So the PIC was on the lower right second molar, plus the bicuspid actually. And I used shim stocks, holding the bicuspid on the bicuspid and the cuspid. But basically, here's the big thing. What do we want to do? Do we want to keep the vertical dimension the same as MI? Do we want to open the vertical dimension to the PIC, the point of initial contact? Do we want to open less than the PIC? or do we want to open beyond the PIC? And because my study models that I initially used were not completely accurate, I said, let's discuss once he does the mounting so we could take a look. So you look here. Here was the initial mounting that I had, which, did match the functional analysis. So I'm thinking if this is what the new mounting, the new more accurate model shows, I believe we have to open beyond the PIC. So we need a little bit more space than this. If you look at the distorted model, which I thought was the distorted model record, this is a lot of space. This is actually too much space. We'd probably mount or build the case less than the PIC. This happens to be the final models and deprogrammer records, and the PIC is the second molar palatal. This is the space. It's more than the original. So these models are more accurate than these. There's just distortion in the occlusal surfaces of those molars, which was probably scraped down a little because of bubbles and ended up closing the vertical more than we wanted. This is more the vertical at the PIC with 7 leaves in. This is less than 7 leaves at this mounting. That's another issue that we were looking at. So this is the accurate mounting with the 2 sets of PV, like polyether impressions and the new byte records. This is actually a good place to build the vertical to. So now with this, we would likely build to the PIC, which is the simplest solution anyway. Once again, you look at this close-up of this impression. It's very hard for much to be able to create a model of accuracy from this kind of occlusal anatomy. It pretty much has to be a super accurate impression material plus a really good well-poured model. And this is Permadyne is the most accurate impression material, I think, in the world. It's what I use for all my full mouth cases for the final impressions. And we had to resort to that for the diagnostic impressions for this case. So here's the mounting. You can see we have plenty of room at the PIC that we could definitely build this case at this vertical position. And the beauty is, due to the geometry of the jaw, if you open the vertical 1 millimeter in the posterior, you will open the vertical 3 in the anterior. And overjet's also affected. For each 3 millimeter vertical change in the anterior, there's approximately 2 millimeters of horizontal change in the AP direction. So if you look at this mounting, we're not end-to-end anymore. We have a better overjet at this new vertical. So this is much better to build the new restorations to than the MI position. And you can't just, hand articulate models on a hinge and say we're going to open on the wax up on a hinge. You won't get the correct AP or vertical position. It's just not going to be accurate enough. So a quick little visualization of what I'm thinking of here. We're basically opening the vertical dimension without increasing the contracted length of the elevator muscle because we are opening the vertical dimension to the point of initial contact with this case. So it's a really good layout and situation. And here, B here represents the contracted length of the elevator muscles. This is in MI, so there's a PIC, but it's not the only thing touching because the patient's closing an MI, and they're not in CR. So if you now seat the patient into CR, seat the condyle into CR, the contracted length of the elevator muscles is the same, but the patient's touching at their PIC. This is this patient that I just showed with 7 leaves in place and a contact on the second molar, plus actually the first bicuspid. And this increases the vertical. This gives us the room we need for restorative material now and a better anterior relationship, a better overbite and overjet. So this is what we need to build the case to. Some cases, this doesn't give you what you need, but this case it does. And it's basically, in this case, it would have been 7 leaves in place, 1 contact in the back, and space for restorative material everywhere else, with the condyle seated into CR and the lateral pterygoid released and the masseter muscle firing. So this is, again, when you have the teeth out of the way and you fire the masseter muscles, they're going to seat the condyle into CR. It's just, that's the way it's going to go. This is dissection from a Dawson course I went to. And a lot of this was germinated from me going to lecture 3 by Dr. Dawson, or workshop 3. where Dr. Dawson actually taught a small group. And chapter 13 of the book is where we got the idea to open the vertical dimension to the PIC. And it works beautifully. Using that even as just the reference point for thinking about where to open your vertical dimension is just awesome. So you look at this. This is the model. These are the models opened to the PIC, like basically just closing the models together after the byte records come out. And they're touching just at the two PICs. There's two in this case. And this is the vertical dimension, the overjet, the overbyte relationship that's available to us to build the wax up to. So this to me makes a lot of sense. We would build the wax up at this vertical dimension. We're not increasing the contracted length of the elevator muscles. We've got the condyle seated in CR. It's a very straightforward way to approach building this occlusion. So I think that this is really good. So how do you design and test the new occlusion for these patients? Well, obviously we transfer the wax up to the patient's mouth with the provisionals. That's how we test. And what happens if they cannot tolerate the new occlusion design? I will get to that in a couple minutes. But part of thinking about the wax up also is how to manage muscle forces and high bite forces with aware patients so you can improve the longevity of the restorations. And that's achieved with force management. So I look at force management, and we have a checklist for this. As I said, if you stick around till the question and answer, we'll post the checklist so you can download this. We'll give you the downloads of this. And here's my force management checklist. And for this patient, what we're looking for, and we go over this with the ceramist who's doing the wax up. This can be included with the wax up instructions. We're looking at what's the chewing and wear pattern. In this case, it's front to back and side to side, so she goes both ways. What's the condylar position? We're going to restore the case in CR. When and where will the contacts occur? We'd like an even distribution. Typically, if you have some teeth that are really structurally compromised, you can actually leave them so that they won't hold shim stock. We'd like an even distribution here. I do recognize that these two lingually positioned laterals will probably not touch once we open the vertical dimension, so that's okay. What's the overbite that we're going to develop? And we'd like to improve from the pre-treatment position with the new vertical. Overjet will also improve with the new vertical. Vertical dimension, originally before the mounted models, the new set of mounted models we looked at, I thought we'd open from the PIC. As it turned out, with the more accurately porn models from Permadyne, we realized that the PIC was the correct place to open the vertical to. Which teeth will touch in the guidance? Cuspids and centrals, maybe upper laterals, but the lower laterals won't. So protrusively, we'll have the centrals. Laterally, we'll have the cuspids. We may include the laterals and the centrals in lateral guidance, depending on how the wax up looks and what we test. What's the angle of guidance? With the amount of wear this patient had on her upper cuspids, it needs to be slightly steeper, but I only would make it slightly steeper. We would try and keep, in most of these cases, the angle of guidance very close to the pretreatment angle of guidance and disclude the posterior teeth by using vertical dimension changes. So we're going to have posterior disclusion and basically the flattest angle of guidance that will still disclude the posterior teeth. That helps with force management. So that's an important statement. You want to create the flattest angle of guidance that will still provide guidance and disclude the posterior teeth. That gives you the best force management, especially bruxers. She's not a bruxer, I don't believe, so I don't believe that it's as critical as with a bruxer, but it's still important. What's the envelope of function? I want to keep this pretty concave because she has already so much erosion. If we developed prominent cingulums, I think it would really bother her. And that's what this drawing is here. It's just basically here she is now with the erosion. I do not want this waxed up with a really prominent cingulum because I think it's going to cause speech and just comfort issues. That's really common with these patients. I want it to be just smooth and not really prominent. And then what's the terminal position of guidance? We'd like all the contact areas as she's discluding to be broad, flat contact areas and terminating on broad, flat contact areas. And what do I mean by that? Well, you can look at this case in provisionals. We have broad areas of contact everywhere. Patient goes front to back, side to side. Side to side, we have broad contact on cuspids, laterals. Protrusively have broad contact on the centrals. Laterally on this side, we have broad contact from the cuspids, transferring over to the laterals in crossover. And sometimes to achieve this, we have to reshape the lower incisors. Especially this case, I'm not doing the lower incisors. I'm going to have to reshape that one that has that kind of high point on the distal and the mesial. Look here, another case. Where patient that we restored with veneers, upper 6 veneers, lower cuspid veneers, didn't veneer the lower incisors. We had to reshape the lower incisors because he had a pointy area here. If he went laterally, we have broad contact, but if we had that pointy area touching as he went laterally, he could have chipped the middle of the incisal edge of the upper lateral. And I know that through painful experience and learning, having seen that on a case years ago. So here I'm really carefully checking. I actually have a video of this on the membership site. Going laterally, broad areas of contact, broad contact. If he's going to touch a lateral incisor in this position, it's going to be on a broad area, not a little sharp edge. Here's the other side. Broad areas of contact. If he's again going to touch the lateral incisor, it's going to be on a broad contact area. If he's going to touch the central, it's going to be on a broad contact area, not a little sharp nicky corner of a lower incisor. The lower incisors have to be re-smoothed in cases like this. So for our case, the diagnostic wax up results. Here's the mounted models again at PIC with the diagnostic wax up. You can see looks really good. We've got a great length to the incisors, I think really good smile design, and a good overjet overbite relationship. Here it is here. Here are the lateral views. And here are the occlusal views. So everything looks good. We've got our PIC here. We've got wax where I'm building up the teeth with composite bonding. So the upper 6 posterior teeth, upper 8 anterior are going to be created with porcelain restorations. And then we're going to end up, what it ended up having was porcelain restorations from bicuspid, or from cuspid back on both sides. And then how to design and test the new occlusion. What happens if the patient cannot tolerate the new occlusion design? And typically that's problems where you've overbuilt contour, especially on anterior teeth. So the patient I'm sharing with you today tolerated the new design really well. She had one spot I had to adjust, one spot on the whole provisional reconstruction. And it was a small little contact. I shaved down a little bit. And everything else was good. She felt great right off the bat. You know, I adjusted that, I think 1 or 2 weeks later, instantly everything felt good, and she was ready to go. So I was able to complete the rehabilitation one arch at a time, basing the final restorations on the provisional restorations. And we can talk about that more, and I'll show you finishing the case. But this is not always the case. This does not always happen. You know, there are many cases that need some form of refinement and testing. So this is one of my VDO case studies. And this patient had a significant occlusal change and aesthetic change and just contour change and volume of tooth structure change. And what we found is he didn't have any muscle or problems with the new vertical. What he did have in the testing phase is he had some issues with being able to say his S's. So he had some S sound issues. So, you know, how do you manage that? If the patient has some speaking issues, usually if they have them the first day I've inserted the provisionals, I'll ask them to spend a couple days just seeing if it goes away. Because a lot of patients, it'll go away within a couple of days, but not always, not always. Sometimes it doesn't go away. And if that doesn't go away within usually a couple days, we have to manage it. So Paul had S issues, so trouble saying S's. And usually that's the palatal contour of the upper incisors, maybe even the cuspids. This particular erosion patient, look at the erosion here. The erosion on these molars is sky high. And he had the similar erosion to the current case on the upper incisors. And he was a Coke drinker. It was like a couple liter bottle a day. We restored him, kind of similar idea to the other patient, except less lower teeth were needed. But we restored him. We had him in provisionals. He had both F and S sound issues. So F sound issues are typically the length of the teeth. And he just didn't feel he could get used to it at all pretty quickly. And he wanted them shorter. So that's fine. We shortened them. So we went from here to slightly too long to not quite as nice aesthetically, but better feeling for him. So it was pretty flat and short, but felt better for him, better with his F sounds, felt just more comfortable. But the problem he also had was S, and S was from the cingulum and lingual or palatal contour of the upper incisor. So you can see here, it was just waxed up, too bulky. So Harold gave him a beautiful anatomy here with nice cingulums, but it was too much. The patient couldn't tolerate it. Look what he was used to. He had erosion like this patient I'm showing you tonight. He had too much erosion to go from there to here, unless he had a huge adaptive range, and not all people have that much adaptability. So he had S sound issues. We flattened the cingulums, and his S sound issues went away. So this had to be flattened out. So here's the model after flattening them, and his S sounds were good. The only issue I had at that point was I didn't prep the teeth hardly at all on the facial because they were so eroded on the palatal. So the provisionals were really thin on the facial. So I said, we need to make new incisor provisionals to test making them thicker because I don't want to make the preps any deeper. And right now we're at 0.3, 0.4 thickness of facial porcelain. And, I can make that work if we have to, but if we don't have to, I'd rather not. I'd rather get closer to maybe a millimeter, maybe, 0.8 of a millimeter if we can't get to a millimeter. But so what I did was I had Harold wax up new facials so that we didn't have to prep the teeth any further. And part of his S sound issue also was just his alignment of his lower incisors. They were just so far out of alignment. This area here had to be really hollowed out. So it just was an issue with the palatal contour. And the other issue could be that you're not in CR with your provisionals. So you made the wax up in CR, but transferring it to the mouth became the problem. And you lost your CR. And so I'd recommend, if you feel that this has happened and the patient's having issues, that you equilibrate the provisional restorations to verify they're in CR. And you can use the leaf gauge to guide the equilibration really easily. And I'll typically equilibrate the provisionals and give the patient time to test out the new occlusion before proceeding with the final restorations. And, depending on the PIC we used, people that were built at PIC the vertical dimension equals the PIC, we typically don't feel that we need to test them as long. People that were built beyond the PIC, open beyond the vertical dimension of the PIC, we typically test those longer because we may have increased the contracted length of the elevator muscles. So once any of these issues have been resolved, and after a testing phase of anywhere from a couple weeks to a couple months, I will complete the rehabilitation one arch at a time, basing the final restorations on the refined provisional restorations. So this particular patient, you can see the final restorations, looks really good. Speech was resolved. All of these issues were resolved. You could see, again, the final reconstruction. His tissue wasn't great at this point. He actually, really nice man. He developed, though, cancer as we were kind of halfway through finishing his treatment. I think when we finished one arch, we're going to the other arch. He developed cancer, was undergoing chemotherapy at this point, and his tissue wasn't great. But Everything turned out great with his reconstruction. His chewing, his speech was really good. And he unfortunately passed away, but he lived a few years after we were finished. I think he had 2 years, 2.5 years. And he traveled a lot and was really like a happy, nice guy and seemed to enjoy unfortunately, the last few years of his life because of freaking cancer. But the rehab turned out really nice. And, what we did was we modified the occlusion, modified the design of the reconstruction to get him to a point where he was really, really comfortable. And then we went on with the final restorations. Same with Paul here, who, I now have 8-year post-ops on this case. I actually emailed them out a few weeks ago with something that I emailed out. I believe it might have been just to my members, but I showed some 8-year post-ops on this case. These were the 5-year post-ops. Case turned out great. No speech or, issues like that. He did chip the first couple months. He chipped his lateral incisors. So what happened was, this isn't chipping on the cuspid. This is a wear facet on the cuspid. So he wore down some of our guidance and he chipped the laterals. And he fortunately hasn't chipped anything since. But it was within the first year, I think, he chipped the laterals. And I think that it was just wear facetting on the porcelain. You do see with bruxism patients wear facetting on the porcelain. It will wear, especially porcelain on porcelain. So he chipped something. He hasn't chipped, knock on wood, anything since. But what happened is that reinforced the need for him to wear his appliance. So bruxism patients, I have them wear an appliance when we're finished. And after something chipped, he said, I'll wear my appliance diligently from now on going forward. And I believe he has, because he hasn't chipped anything since. So how do you choose the best restoration design for individual teeth in an erosion or attrition case? And should you choose crowns, onlays, veneers, occlusal veneers, veneer crowns? What are all these? So let's look at restoration design on these wear cases. This is another one of my vertical dimension case studies. We opened the vertical dimension with veneers and onlay veneers and occlusal veneers on his lower arch. So we did his lower arch and some remake of anterior bridges on the upper arch, but we did all the vertical dimension heavy lifting on the lower arch. And you can see these are feldspathic bonded ceramics from 14, 15 years ago, or 13 years ago. And we've opened the vertical with these restorations. And this is an occlusal veneer. This is an occlusal veneer. This is an onlay veneer. So it has a veneer on the facial plus an occlusal veneer. And then the front were veneers. And here are the preps. Occlusal veneer, kind of a occlusal veneer with maybe a slightly bit of a facial veneer. Here's an onlay veneer or occlusal veneer, facial veneer, occlusal veneer, facial veneer, facial veneer. Here's the 12-year post-op for this case. Beautiful reconstruction, still going strong with fairly weak restorative materials. These are feldspathic restorations. They're not even EMAX or lithium disilicate. So this was the 1-month post-op for this case. Here's the 12-year post-op for this case. And this is the weakest restorative material we have. It's basically layered feldspathic porcelain built on a restorative die, a refractory die, on an occlusal surface opening the vertical dimension on a deep, deep overbite patient. So what does this show? This shows that maybe thinking that strong restoration versus a strong tooth is not the right way to go. Our ceramists and our manufacturers want you to have the strongest restoration at the expense of having the strongest tooth because they want so much restorative material thickness. That's counterintuitive to what's best for the patient in some cases. I would rather, and I have this discussion with patients, I would rather have porcelain fracture than a tooth fracture. I'd rather have a weaker ceramic than a weaker tooth. So you look at this patient, I could justify buzzing all the teeth down for crowns. They could be, heavy duty, chamfered, shouldered crown preps. But I could also do this a different way. And I could do this with really conservative porcelain restorations bonded to these teeth. I don't necessarily have to buzz all of these teeth down for fairly aggressive cemented restoration. So we have different options today. And you look at the wax up, we designed this case to be more of a bonded case with less aggressive preparation design. And we designed this to think about, we'd rather strong tooth versus strong restoration. So I felt that we'd have a strong enough restoration with bonded ceramics, and even using Emax in some of these posterior situations, as opposed to buzzing the teeth down that are already structurally compromised to just for the sake of getting a stronger porcelain restoration or cementing the porcelain restoration instead of bonding the porcelain restoration. So my guiding principle when I'm thinking about preparation design is I want to maintain a strong tooth. So you look at preparations for this case, this patient. We did a mock-up for this case because I knew there were two places that were going to be really close to the outside edge of the desired restorations. So we did a mock-up. I have a video of this that I shared with members where I cut the depth grooves and then I prepped based on the mock-up. And really a lot of the areas were additively contoured. You can see a lot of the areas we have pretty good thickness of mock-up, but right here we're going to have to prep the teeth because that was out of the arch form and this one was out of the arch form. So that's the two places on the pictures that I sent. So we're going to prep those two places a little more. Everywhere else, we're going to prep pretty minimally. And then the posterior teeth, they're already prepped. In the upper arch, the bicuspids were already prepped essentially. So there was so much erosion on the posterior teeth, the first bicuspids, and then the anterior palatal surfaces of the anterior teeth. I basically wasn't going to even run a burr on all the erosion areas. I just decided I'll run a finish line around this tooth, and that's going to be the prep design. Now, it's not very retentive, but we're going to be bonding to this. And then the second bicuspid, I was going to bond a restoration with composite, direct composite, and I was going to bond the palatal cusps of the molars. So you can see here's the wax up. Wax up was done to be additively contoured from the erosive situation. So all of this erosion on this patient that she started with, I basically didn't prep. I just prepped a finish line around the palatal. And you can see it's not a heavy chamfer, it's a very light chamfer. And then the other thing I did here, you can kind of see all this discoloration. What that is I did immediate dentin bonding. So this is from the etching and the Gluma desensitizer. So I've bonded all of the dentin. So I've done immediate dentin sealing or immediate dentin bonding, whatever you want to call it. I've basically sealed the dentin and made it ready for final restoration. And that helps with our bond strength to restorations that are largely bonded to dentin. Now, I left all the facial enamel on these teeth. So we've got lots of facial enamel to bond to, but on the palatal, she had eroded all the enamel away, so I'm bonding to, other than the finish line, dentin. So to increase my bond strength, I went with Dr. Pascal Monier's technique with immediate dentin sealing with Optibond FL primer plus separate adhesive 4th generation. So here's the facial preps. You can see I basically put a very light finish line. And there were some places I had to prep a little bit more because of two teeth sticking out, but for the most part, I haven't prepped that aggressively, and everywhere it's all enamel still. So this is all enamel preparations on the facial. I've bonded now at this point the posteriors, but here's the immediate dentin sealing. Here's the other side, bonded posteriors, immediate dentin sealing. And all I've really done on these teeth is drop a finish line around them. And in some cases, 2 cases, I had to prep some of the facial. But otherwise, we're trying to keep this as close to the original tooth form that we had, as close as we can to, while still restoring the teeth. And then the lower is a whole different animal. We had a lot of facial erosion on the lower cuspids and bicuspids, so I didn't have to prep that very much. I'm basically doing a V-shaped veneer on the two cuspids, more of a V-shaped veneer. Bicuspids, this one's getting a more of a veneer. This one's getting an onlay veneer, not even breaking contact. Here we had to break contact because she had interproximal decay. This was a first molar treated with an endo. Sorry, this is a reversed image. It's done with a mirror. First molar treated with, had an endo, so we did a core buildup and full coverage. This tooth we just wanted to build the occlusion with. We wanted to redo the occlusal anatomy. And there was erosion, so we just did an occlusal veneer. This one had a crack on the distal, so we decided to do a full coverage because it was cracked moderate. I was debating an occlusal veneer, but we decided full coverage because of the crack. I couldn't chase the crack away. This one was endo treated, so it was full coverage. This had distal decay, so it's kind of a funky onlay veneer. This was a kind of a real basic onlay veneer, almost like an L shape. This was a V-shaped veneer. These were not treated. So kind of the least amount of preparation for each tooth that I could do to bond restorations to the teeth. So we do a testing phase with this. We always have the whole reconstruction done in plastic to test. We don't finish just one arch because it's just not going to work against the opposing starting arch. So we have the whole mouth rehabbed in plastic plus areas that are going to be composite, and we test. And so we test for a few weeks. Patient came back. She found one spot, the palatal aspect of this one central, this lower central that was rotated out. The distal corner was hitting the palatal aspect of this temp. So that just needed to be a little hollower. Once that was done, the comfort was perfect. She had a little lisp because this was hitting prematurely, and that went away immediately. Otherwise, everything else was good. Vertical was built to the PIC, so that's all good. New form of the teeth, smile design, anatomy was all good. Overjet and overbite were good because these are much longer teeth, and the overbite and overjet were definitely good with the provisionals. So she was very happy with the provisionals. I was able to complete the rehabilitation one arch at a time, basing the final restorations on the provisional restorations. Our plan right from the beginning was to complete the lower arch first. So we went into lower arch completion. So here are the lower provisionals, onlay veneers, crowns, occlusal veneers. This was before we made the provisionals of the lower arch. I did take the final impression at the prep phase because I didn't want to have to take off these onlay veneers and occlusal veneers and everything, because it's very hard to get those provisionals to stay in place, and it's even harder to get them to come off if you've locked them into place. So we took the final impression at the prep day. The upper we didn't. We took the final impression after we had tested everything, but the lower we did, and that's how we planned seating the lower case first, the lower arch first, because of this. So here are the preps again. Here's the lower preps against looking at the lower plastic restorations. Here's another view of the lower preps. Once again, kind of a V-shaped veneer for each cuspid. Onlay veneers and veneers on the bicuspids. And then this one back here is an occlusal veneer. So some interesting, prep design. And if you look at the way the teeth look before and after, we mostly, especially the bis, we mostly just smoothed them out and put finish lines on them because there was so much missing tooth structure. And then this side. Once again, these smoothed them out, put finish lines on them. I had to break contact here just because it was rotated so much. But here it was mostly just smoothing out and putting finish lines on them, although I had to dig out some distal decay on this one. That's why this looks funky. This was endo-treated molar with a big restoration. This was a molar with a large restoration and a distal fracture. So because of that, I chased the fracture. The fracture wasn't going away, and it looked like it was going into the middle of the tooth. So I decided to go full coverage on that. If the fracture went away when I was chasing it, I might have just built up a base and done an occlusal veneer. And maybe that would have been good anyway, but I decided we'd do a full coverage on this particular case. So the lower porcelain restorations, if you look here, here they are. Gives you kind of a visualization of the ceramics. You can see the V-shaped veneer here, the V-shaped veneer here, the veneer here, the occlusal veneer, PJC, occlusal veneer, occlusal veneer, occlusal veneer, PJC, BJC. Material-wise, the 4 molars were Emax, okay? Monolithic Emax stained. The bicuspids and cuspids were layered feldspathic ceramics. So we could have done the whole thing in Emax probably, but we do like the aesthetics of the layered feldspathic ceramics. So we used that where it was visible. And everything else was occlusal, the other 4 were Emax monolithic. Now occlusal veneers, these are interesting. When you have it, it's just kind of a tabletop. I put some seating like jigs in it. I put some knobs or whatever you want to call it. I basically sink some seating retention points. And it's not really for retention. It's more just to help me seat the thing. Because if I have it and it's just flat, it slides when I try to seat it. And it's very, very difficult to perfectly position the thing. So I find it's much easier if I have just a couple of little fissure grooves in the prep. So that was done intentionally to give me something to seat this with, because it's just a tabletop veneer, an occlusal veneer. I need something to help me seat it with. And if you look at the thickness, the monolithic Emax crown is about 1.3 here. The occlusal veneer at its thickest was about 1.3. At its thinnest, it was about 1.0. The feldspathic occlusal was 1.0 on the occlusal aspect. And then the veneers, the veneer portion was about 0.7 here, millimeters thick. So about 0.7. And so we finished the lower arch. Then we're testing the finished lower arch with the opposing provisional. And this is our last chance to test the design of the case. And it's a good opportunity to really test things. So you can see how Harold's created the flattest angle of guidance possible to still disclude the posterior teeth. So that's on these lower cuspids. And now we can test this extensively with the upper cuspids. And if everything is good, we go forward with the upper final restorations. So testing was good with this case. We had good disclusion. We had broad contact areas. You can see where I reshaped this lower cuspid. Everything looked good. Comfort was good. Again, disclusion is good. Broad areas of contact. We decided we were good to go with finishing the upper arch. So here's the provisional. At this stage, then I had to take the upper final impression. I hadn't taken it yet. Because the reason I didn't, if you're wondering, is because when I was planning the case, I knew I was going to bond the upper bicuspids and upper palatal cusps of the molars. I didn't know really how much bonding was the right amount at the prep day. Because at the prep day, I didn't have any time to test the occlusion. So for me to assume that my bonding is exactly correct and take a final impression is fairly presumptuous. So any arch where I have bonding to do to change the occlusion, I don't do the final impression the day that I do all of that, because I have to verify it was in the right place. As it turned out, there was very little change made, but I think there was a little polishing. So, it's just the lower arch had no bonding. I could finish the lower arch final impression the day of prep because there was nothing else to change. But the upper arch, the bonding could have changed moderately. So I couldn't take the final upper impression the day that I placed the upper provisionals and the upper bonding. So we take the final impression after everything's verified. You can see we've already done immediate dent and sealing the initial day. We just didn't do the final retraction and impression. So we did the final impression. You can see, again, these preps are really ultra conservative. They're what I call veneer crowns. because they're just not prepped aggressively. Even if you look at occlusally, I didn't really prep these teeth. They were prepped by erosion. I just put finish lines on them. So these are what I call more veneer crowns. Harold, I think, classifies them in his billing as glove crowns. But if you look at the upper porcelain restorations, again, here are the preps. They're not prepped heavily. We've gone with strong tooth versus strong restoration. These are all feldspathic layered ceramics built on refractory dies, and they're not thick. You can't tell from here because they've been layered with some dent and opaquer, but they're not thick. They're not really thick. These are mostly 0.7 millimeters in many places, 0.1 on the occlusal surfaces, but 0.7 on the palatal of the incisors and cuspids. So this is strong tooth versus strong restoration. Strong tooth versus strong restoration. And those teeth had so much erosion, I couldn't justify in my mind prepping them deeper than I did. So you look at the opposite of this. This is strong restoration versus strong tooth. So this is a case that I redid for the patient. And I had to prepare the laterals and the cuspids, but the centrals were already prepared. And this gives you a good visualization of, traditional preparation thickness of restoration versus my preferred veneer crown, glove crown, whatever you want to call it. It's a significant difference. And yes, this is a weaker porcelain, but it's bonded. So it's bonded. It shouldn't be that weak. But you look at the preparation change. These are my preparations. This is that case that I just showed you, the occlusal or the inside view of the restorations. These are my preps compared to these traditional older preps, older crown preps. Look at the difference. And look at the difference here, though. This is the difference that counts. These are much stronger teeth for the rest of this patient's life than these centrals. And one of them, I think maybe both of them, happen to be endo-treated. So these are just much weaker teeth, prepared that aggressively. Here are the final restorations, look good. Even with variable thicknesses and variable substructure colors, we can do that with feldspathic bonded ceramics because it masks layers of opacity better. But look at the difference in preps. I'd rather prep the teeth like this than like this. I'd rather strong tooth rather than strong restoration. Here's the case we're currently looking at, occlusally, where we're just about 1.1, maybe 1.1 and a half, or 1.1 millimeter. 1.1. Here we're a little under 1 millimeter on the facial. Here's another occlusal right around a millimeter. Here's another important point from this case. Here are the provisionals. And as I hope you can see, I've made a big mistake with this provisional, and I saw it, fortunately, before I seated it. And the big mistake was I didn't carve the embrasure enough. And I didn't carve this embrasure enough either. So you can see after carving it, here's seating the provisional. Nicely carved embrasure. If I had left it as blunted as I was, I would have had a terrible papilla at insert. As it is, I didn't carve this one enough, even though it looked like I did here. But you can see the provisionals after months in place. Tissue looks good. The papilla look good. Here's the try-in of the porcelain restorations at seating day. I actually blunted the papilla between the lateral and cuspid, central. Didn't really blunt the papilla between the centrals. This was pretty good. But I blunted this one. This wasn't carved quite enough here, even after recognizing an additional carving. So not a lot, though. Only blunted it a touch. And that will rebound, and I'll show you rebounding of the thing. So here's the before and after. Looks pretty good. It's one of my favorite new smile designs. I made a new book to have it because I like it so much. Lateral views. Pretty dramatic case. If you look at the lateral view here, look at how all these teeth were rotated and sticking out and how this is all nicely lined up now. Or even this lateral view, this was sticking out significantly. We've lined everything up better here without being bucky and too thick and too facially inclined. Here's a view of what the beauty of feldspathic layered ceramics can look like, with all the different layered colors coming from the inside out. This is porcelain. This is her natural tooth. It's a pretty damn good match. This is her natural tooth. This is the porcelain. So I like, Harold likes, we like layered feldspathic ceramic. Here is the blunted papilla about 2 weeks after insert. So it's slightly blunted. Not terrible, but slightly. Here's the roughly two week insert. Here's the roughly 2 week insert. And here it was, I think, a month and a half post-insert, so it's almost resolved. Papillas are looking pretty good. Tissue looks pretty good. Here it was this week. I saw her on Tuesday. So it's mostly filled in now. Although this picture was taken in a different part of the office, so it's a little off on the white balance. You can see the difference between my op and the hygiene op. Just the colors of the walls reflect on the white balance a little bit. Here's the before and after, though. Papillas are filling in. Everything's looking good. Tissue looks pretty good. Here's the occlusal. You can see the final occlusal results. Again, more like glove crowns or occlusal veneer crowns on the upper, V-shaped veneers here, veneer here, occlusal veneer, occlusal veneer, occlusal veneer, occlusal veneer here, jacket crowns here. These are Emax. These are feldspathic. This is a good comparison here before and after. You can see the changes that we made to the arch form and what we've done to restore this patient and resolve the erosion problem. You can see the lower arch, the changes we've made, and what we've done again to resolve the erosion problem. So this case, and all the cases I think I showed tonight were completed by my ceramist Harold Heindel of Aesthetic Dental Creations in Seattle. Harold's actually trained in Washington State, but he's trained in Germany. He's a master German dental ceramist, very prestigious designation, but he works in Washington State. And what I've tried to do is alleviate some of the occlusion confusion associated with these kind of cases, these wear cases. And the people who have influenced my restorative dentistry and my occlusal philosophy, I'd say, are Dr. Peter Dawson, Dr. John Coys, Dr. Frank Spear, Dr. Jimmy Eubank, Dr. Jeff Morley, and especially for bonded porcelain restorations, Dr. Pascal Monnier. And, I've been lucky to have some exceptional teachers and mentors, especially when I was a young dentist. And if you look at Steve Jobs, he said something that I think is brilliant. And he said that you have to go out and expose yourself to the best of what others have done and bring some of that back and add it to what you were doing. And I took what I learned from all of these masters of dentistry and I created systems designed to help the wear patients in my practice. And as I said at the beginning, helping wear patients will increase your practice productivity. It's going to increase your billings, your production. It's going to help everything in your practice being able to help these patients. And it's going to help the patients because these people don't always know where to go. So I learned how to help these wear patients, and it really developed. It needed me to develop the mindset that A, I want to help these wear patients. B, I can help these wear patients. But ultimately, I had to learn how to help these wear patients and create systems. But the first mindset is I want to help these wear patients. Then you have to figure out the systems to use. And then you just have to develop the mindset that I can help these wear patients. It's just a mindset of I can help these wear patients. And you can learn how to help the wear patients in your practice because I learned how to help the wear patients in my practice. When I was a young dentist doing veneer cases, I was scared of these wear cases. I truly was. I didn't know what to do. I didn't know how to take the bite records once all the teeth were prepared. I had a lot of questions. But I had the mindset that I can help these patients. I just need to learn how. And, I had a big vision of what the practice could be, even though I was a young dentist. And I'm still in the same practice I was at in 1992. I built this office when I graduated from dentistry. Now we've expanded and we've renovated, and we're about to expand again. I'm adding another 1,000 square feet. I kind of bought out the convenience store next door, and they just put up the demising wall right now, started today, and we're adding 3 more operatories and a large lab to the practice, and I'm going to add another dentist. So, that's just my big vision of what the practice should be and can be and will be. But, I think, you have to have a big vision of where you will be and where your practice will be. And the bottom line is where you are now does not dictate where you will be. When I was a young dentist and I was doing only veneer cases and a lot of bread and butter dentistry and not having the confidence to take on the wear patients and being afraid of wear patients, my vision was that I could do this one day. I just wasn't quite ready because I didn't have the training. But where I was then did not dictate where I will be. And I'll tell you, I was pretty frustrated as a young dentist because doing bread and butter dentistry can be a little commoditizing. Not being able to create distinction of your practice gets commoditizing, and people just, they don't show for appointments, they cancel, they don't book what you suggest. Once you've developed your ability to be able to treat patients like this, you decommoditize your practice. Because you're not a commodity anymore. You could do something that a very small percentage of dentists can actually do at a very high level. So you decommoditize your practice. You don't get no-shows. You don't get canceled short notice. This was something that drove me mad as a young dentist. I actually was so frustrated at one point, my first few years into practice. I remember being so upset and frustrated at, I had a Saturday, I was working Saturdays, it was crap. And I had a Saturday where we had all these canceled no-shows and short notice cancellations. And I remember sitting in the little office we had in the old part of the practice before I'd expanded to the current configuration. And I remember sitting there so pissed off and upset at cancellations for the day, blowing up half the day and everything. And I was just not happy. But, I had a vision of where the practice could be, and I just had to make that happen. And that's what happened. And since that's happened, it takes a little bit of time, but once I was able to deliver the goods, the practice transformed. I can't remember the last time we had a no-show for my schedule. It happens occasionally still in hygiene, I think. But it's so rare. People know it's so hard to get appointed with me that it just does not happen with me. I can't remember the last time. And I can't remember the last time we had open units in the schedule. For me, never. It can happen occasionally with hygiene, but for my schedule, never. Doesn't happen. So, where you are now does not mean that's where you're going to be the rest of your career. So if you have a big vision for your practice, I'd like to introduce you to my occlusion design training. Because if you have a big vision for your practice, if you're interested in this kind of dentistry, if you want to help the wear patients in your community, occlusion design is specifically for you. And it's really my flagship online training and coaching program. I've designed the curriculum to teach general dentists the systems to improve your restorative dentistry and manage more complex wear, aesthetic, and full mouth rehabilitation patients. And as I said, this is an online curriculum. There's no need to travel. You can watch this on your computer, on your iPhone, on your Android phone, on your tablet, on your laptop, anywhere where you can find an internet connection, you can connect and enjoy the online curriculum and learn from the online curriculum. And this is important in these, in these days of self-isolation, with this global COVID-19 pandemic, I found myself in self-isolation. We went out to Turks and Caicos for a family vacation before the pandemic really started and escalated. And suddenly the government of Canada is advising all Canadians to come home. So I had to rebook my return flight, come home early. Then you find yourself in 14 days of self-isolation. My practice is closed. So, I could either spend all my time watching Netflix, or I can improve kind of my online learning. And I think that a lot of us in this situation where we're either practicing a lot of social distancing or our practices are closed, it's a good opportunity for some online learning. So that's where this fits in very nicely. There's no travel required. This is a comprehensive online training for restorative dentistry, smile design, and rehabilitation cases from the comfort of your home or an office. And recognizing that this is a pretty uncertain time with a lot of us having our offices closed, I've decided to recreate the membership to have a occlusion design digital membership only offer for all of you. And this saves $1,000 from my usual occlusion design membership. So my usual membership that you would see if you had watched this webinar even yesterday is one payment of $29.97 or 4 monthly payments of $8.47. And we've changed this to a digital only membership where we don't have to mail you a bonus package. And this is a less expensive version. So it's $1,000 off. It's now one payment of $19.97 or 3 monthly payments of $6.95. And with this, you're getting a complete online library of CE courses. So let me share with you the different programs you're going to receive with this Occlusion Design digital membership. You're going to receive Occlusion Design, of course. You'll also receive my Functional Occlusion online seminar recordings. So that's the complete recordings from my 2-day seminar, Functional Occlusion Online. You'll receive the complete recordings from my 2-day seminar, Occlusion Design Live Toronto, and the Occlusion Design Live Montreal seminar. You'll receive the Rehabilitation Systems seminar recordings. You'll receive our portal for Occlusion Design team training, where my assistant Amanda was teaching monthly coaching webinars for team members. And if you join during this webinar, you're going to receive my full mouth rehabilitation case studies seminar recordings, which was a 2-day seminar I recently completed teaching full mouth rehabilitation case studies, a number of different case studies from A to Z. And this was a really popular seminar, 2-day seminar. You have the complete recordings here in your portal. Let's look at Occlusion Design first, quickly. And if you look at Occlusion Design, and with these portals, with this membership, you've got the navigation over here on the left-hand side. You have Occlusion Design main course, and it's a modulated course, modules 1 to 6. And inside each module are the module videos. And these are detailed videos. We have the introductory presentation. So module 1 is comprehensive diagnostic records. We have the introductory lecture, which is about, in this case, 2.5 hours. And underneath each video, you have a description. We're just working on new descriptions at the moment, and module 1 is all completed. You have an area where you can ask questions, and I'll go in and answer. You have downloads for each module, and then, of course, the module videos. If you go back to module 1, we've got the main lecture. We have video for pouring study models. We have some videos for impression taking techniques. That's part of team training as well, but also will be great for you to reference right here in module 1. We have diagnostic wax up. We have mounting study models, the introduction and protocol, and the demonstration. We have model analysis. We have a lecture about identifying patterns of wear that you would look at as part of your model and photographic analysis. We have a demonstration of the functional analysis, demonstration of using the leaf gauge, demonstration of the Lucia jig, Coy's deprogrammer, face bow, another demonstration of mounting models on the articulator, and then the module 1 webinar, which includes basically a couple of additional videos showing and demonstrating using the leaf gauge technique for CR. So this is a very comprehensive module about comprehensive diagnostic records. And then module 2 is risk assessment for complex cases. With risk assessment, you get our risk assessment download that you can use in your practice. This is a very detailed training as well, and it will help you really identify the risk associated with treating some of these patients, especially a high-risk wear patient. And this is something that people struggle with, is the wear patients in their practice. So this will help you identify and also communicate with the wear patients, because the wear patients, they need to understand what parts of their treatment and their dentition are at risk for treatment, without treatment, and what's at risk if they do nothing. So this is a good module to help with risk assessment. Module 3 is treatment planning complex cases. So this follows very detailed training about treatment planning the wear patients again, but also treatment planning aesthetics for implants and teeth, and basically, again, altering the vertical dimension, for example. It teaches in detail about force management. Force management is a big part of treatment planning. And then taking the treatment plan and transferring that to the diagnostic wax-up is another important aspect of all of this. So that's here as well. Module 4, let's go back to the main course, is pre-treatment case presentation. This is really good because it's really going to help with your restorative dentistry, because we talk about rebuilding the structurally compromised tooth. And we're talking about posts, core buildups, post and cores, etc. I have a core buildup technique that I've been using for 25 years. And if I happen to be cutting off an old crown from the 90s and they had this core buildup technique, it's one of my cases, the cores look incredibly good. So say we have an old metal ceramic crown and some of the veneering porcelain broke and I cut off the crown to replace it. The cores are unbelievable, even 25 years ago from the 90s. It's really quite stunning. So that's module 3 at the beginning, is rebuilding structurally compromised teeth. Then it goes into altering the gingival levels around teeth and implants. And it goes into teaching you about equilibration. So we have trial equilibration plus the actual equilibration on patients, with video showing the actual treatment on patients, both kind of operatory views and microscope views. So it helps you really see that particular procedure in detail. And we showed 2 different cases for this as well with the equilibration. So this is, equilibration is really good for a number of things. For veneer cases, there are a lot of veneer cases that can benefit from an equilibration if they have a slide that slides the mandible into the front teeth. It's also good to have equilibration skills to equilibrate provisionals on a full mouth rehabilitation type of case. And it's also good for equilibrating bite splints. So the principles are almost the same between all of these things. Once you have the principles down, you could really figure it out and use it easily. Because I use a leaf gauge technique, and the leaf gauge is exceptionally good for equilibrating teeth, equilibrating provisionals, and even equilibrating a CR type of bite splint. So that's module 1, that's module 4. Now to module 5, we have preparation techniques. So this is teaching you about preparation techniques for onlays, veneers, crowns, all of these types of different restorations. It also teaches you about provisional techniques, and it teaches you about different types of preparation techniques, whether it be the diagnostic matrix technique where you make a mock-up and cut depth guides into the mock-up. There's just a lot of different detailed techniques in this module, as well as different veneer provisional techniques also. So this is a great module, very detailed number of case studies. Then module 6 is bonding cases, but it's also precision restorative records. So the records that you need when you've either prepared a whole arch of teeth or the whole mouth of teeth, there's specific records that we use both in the dental practice and in the lab. So in this lecture, my ceramist joined me, Harold Heindel, and we spoke about lab restorative records and, in the chair restorative records and how they work together. So it's a very nice lecture, and I think you'll enjoy that. And there's also with this a step-by-step protocol that you could download for restorative records that will help you. And it's kind of like a checklist. And then I share a number of different bonding cases. I share this case, which is bonding in a veneer case. It's now about a 15-year-old veneer case, which looks exceptionally good still. But this is video I did basically 15 years ago with my microscope, with my Zeiss microscope, and made this video series. And I know that this works well because the case still looks great 15 years later. And I've posted that case post-op, longer-term post-ops to the Facebook group. And then there's this case, which is a full upper arch that I treated on another dentist. In this case, because I was treating a dentist, we were able to videotape the whole thing in detail, start to finish, even the bite records. So this was the bite records stage, but we also videotaped the bonding in of the upper arch. Again, step-by-step, operatory views as well as views right in the microscope that you can see really close up exactly what I'm doing. Also, you're seeing where people can ask questions and I'll go in and answer them. This video series was really unique because, again, I was treating a dentist. Because I was treating a dentist, I was able to speak freely as I was treating her and explain what I was doing. I wouldn't feel comfortable speaking about every technical aspect of what I'm doing when I'm treating a patient because it might freak them out a little bit. But this being a dentist, I was able to speak openly, freely, and talk about what I was doing, and it worked out really nicely. And if you look at the videos, you have full control with the videos. You can forward or reverse. You can play them. You could stop and reverse. You can make them full screen. They look very good full screen. It's just a really nice system to consume online content and online CE. So that's module 6. After the core modules, we have applied occlusion design, which shows 4 different full mouth cases in detail, start to finish. So it's the entire case, start to finish, using the systems from the core 6 modules. So those are more case studies that you can look at. We also have the coaching webinars. So we have, I think, about 7 years worth of coaching webinars here. The coaching webinars, again, show the case studies that I'm doing in my practice right that month. Once again, these can be made full screen. And let me just turn down the volume there. So with the coaching webinars, I share cases that I'm working on that month in my practice. And if you look, they can be made full screen. Very, very high def videos. Turn down the RPMs on my So you can see these videos are very detailed. So what we do in the coaching webinars is I present one of the cases that I'm working on in my practice. I present that for probably the first hour and a half of the webinar. Then I answer questions. And then we look at members' cases. So we have members basically asking questions sometimes. So we answer those. But we also have members with their specific cases that they submit ahead of time, and we treatment plan and talk about their cases and troubleshoot their cases. So we look at members' cases each and every month. It's one of the fun things about the monthly coaching webinars. And if you're a member, you can submit cases every month or submit the same case sequentially as you're going through and working on the case, and I can help you with your case. So that's why this is an online curriculum, but it's also an online coaching program because I'm helping members with their cases each and every month. And the nice thing is you're seeing new cases that I teach with, that I I've treated in my practice that month. So you're seeing new content each and every month with this program. Each and every month you're seeing new content. So that's what the coaching webinars. We also have a digital photography module. With the digital photography module, you see exactly how I take photos. And you'll see how I edit the photos, but you'll also see exactly step by step how I take the photos in the photo series that we use for communicating what we do for our patients. There's a bonus area where we have some of our guest speaker seminar recordings. So we have Simplifying Bone Augmentation by Dr. Naheed Mohammed. This was a 3-hour webinar by Dr. Naheed Mohammed showing some detailed bone augmentation techniques. We have PDFs from Dr. Monnier. These are a series of PDFs from Dr. Pascal Monnier about techniques that he taught during his online seminar. We have a online webinar from Dr. Michael Picos, crestal sinus grafting using osteodensification burrs. Excellent, another 3-hour presentation. We have another 3-hour presentation on composite resins by Dr. Bob Margis. Practical tips and tricks for making your composite resins better. So these are special series seminars that we basically have for our members on a regular basis. I'm in the process now, since a lot of us have to stay home at this time. So I'm looking for some speakers to add some additional special series members presentations. I put a couple of emails out today. I expect I'll have a couple of speakers booked for over the next couple of weeks that we can learn from as we're going through and, learning this online platform, all this online content that I have for you. So I'm planning to have some additional speakers as this pandemic is going on, because a lot of them are available right now. Most of the dental meetings have been canceled and probably will be canceled for the next 3 to 6 months. And quite frankly, I wonder if I want to go to a huge dental meeting anymore after this, at least for the next little while. I'd probably want to wait till later in the year. So this online environment, I think, can be very good for us to learn. So here's functional occlusion seminar recordings. Again, the portals are all similar. This one has day 1 and day 2, plus the CE test. There's CE tests for each module of occlusion design as well, by the way. And then occlusion design module 2, or functional occlusion online day 2, sorry. The manual, so there's the manual you can download. There's a bunch of different downloads here, and there's some bonus videos. So this is another nice platform of training in your portal. We've got Occlusion Design Live Toronto and Montreal. Those are 2-day seminars. We've got the systems training, which was a nice little lecture that I did, an 8-part lecture about the different systems that I use in occlusion design. It's not detailed like the core modules, but it's a good overview. You might enjoy watching that. We also have team training. With this, you can, if your team members are basically looking for something to do over the next little while, this can be really good for them, because basically we're going through and we're teaching. Basically, I'm not teaching it. My assistant, Amanda, is teaching different aspects of work that the team members do so that they can learn how we do it in our practice. So there's clinical photography. There's 2 webinars on clinical photography. There was mounting models on the articulator. I believe there was 2 webinars for that. There was setting up a procedure manual and restorative procedure setups. So it was basically setups of different systematic setups of kits that you would use for different procedures. And Amanda gave our kits that we use as PDF handouts for your assistants so that they can reference that and all the materials and supplies that we use. And then there was basically a webinar on using Optogate and Isolite, which I think are really excellent tools, but some assistants struggle to put them in. And then there were 2 webinars on Rubber Dam. Again, another excellent tool that some team members struggle to place. I don't place the rubber dam in my practice, but I use a rubber dam on almost everything. Amanda places the rubber dam. So she's teaching how to do this with, again, videos on all of these. We shot separate videos for most of these webinars. And then there was a webinar on impression taking, actually, too, on impression taking. Excellent trainings on impression taking. And then there was a recent webinar on fabricating putty indexes and putties and stents. And there will be another team training webinar in April that will teach the different hard cast plus copyplast stents that we make and use for rehab cases, veneers, etc. The type of materials that I use to create provisionals, mock-ups, and just to check the depth of preparation. Now, when you join today, we've got this extra bonus, which is Full Mouth Rehabilitation Case Studies Seminar, which is day 1 and day 2. So here it is. This is a full 2-day seminar about full mouth rehabilitation cases in lots of detail. And again, you can make it full screen. You could watch it smaller, but you could also make it full screen. You could forward and rewind. It's really a nice seminar to be able to look at these full mouth cases. So this is day 1. And then we have day 2. And so with day 2, I looked at this really complex full mouth implant plus tooth rehabilitation. We looked at precision restorative records. Again, Harold joined me to talk about that particular part of the day 2 presentation, kind of an updated presentation with Harold and I. And then we looked at which arch do you complete first. This was detailed part of day 2. When you're doing a full arch case, a full mouth case, a lot of full mouth cases, we have to decide which arch to complete first. Usually I don't complete the full mouth at once. I usually select an arch to complete first and then test the completed arch against the plastic teeth, the plastic provisional arch, make any changes to the plastic provisional arch to optimize the case, and then finish the second arch. But there's specific guidelines here about which way to pick that. And then, day 1, the second half of day 1 was all on phasing cases. So it was treating cases with partial rehab in porcelain, the rest of the rehab in composite resin, because some cases are better treated, not full mouth porcelain, but maybe partial porcelain, partial composite resin, because basically not everybody can afford the full mouth rehabilitation all at once. And that might be the case for the next year. So we might be having to phase a number of cases over the next couple of years, even depending on the economy. So phasing could become a huge part of what we do for helping patients, because some patients, they need their vertical dimension altered to be able to create room for restorative material, but they may not be able to afford a full mouth of porcelain restoration. So this phasing section of this 2-day seminar, I think, is very important. So that's another thing that you get. You'll receive that bonus if you join today during this webinar. So that's basically the portal. Here is the order form, very simple. 1 payment of $19.97 or 6 monthly payments of $6.95. So that would be a payment of $6.95, then 30 days later, the next payment, then 30 days after that, the next payment. And basically, this is a 1-year membership. You'll receive access to the whole portal for 1 year and 12 monthly coaching webinars. After a year, you'll have the option to renew your membership for 1 payment of $997, or I think it's 3 payments of $300 and something dollars. I'm not sure the exact amount. It might be $350. But 3 equal payments of around $350 or 1 payment of $997. That's the renewal. And many people renew because we have special series webinars or seminars every year, different speakers, guest speakers, and people also like the full monthly coaching webinar that I present. And, there's a lot of content here in this portal. It gives you more time to go through it or go through it again. A lot of people like to go through specific parts a second or third time before they do those procedures.
So this is your library. This is the order form. Once again, order today, and you'll receive full mouth rehabilitation case studies as an additional bonus. And just to review or recap what you'll receive with this, you're receiving a new online portal with occlusion design and 5 different seminar replay video membership sites, including full mouth rehabilitation case studies replay video portal for that particular seminar, the webinar replay video from Dr. Robert Margis, practical tips and tricks for making your composite resins better, the webinar replay video from Dr. Michael Picos, crestal sinus grafting using osteodensification burrs, the webinar replay video from Dr. Nahid Mohammed, simplifying bone augmentation through key principles of regeneration, the Functional Occlusion Online Seminar Recordings Portal, the Occlusion Design Live Toronto Seminar Recordings Portal, the Rehabilitation Systems Seminar Recordings Portal, also the Occlusion Design Live Montreal Seminar Recordings Portal, the porcelain veneer before and after case JPEG downloads. So these are some before and after case photos that are available as downloads that you can download and use in your practice. What some people have done is they've basically printed them, put them up on the walls of the practice, and people ask them about porcelain veneers based on these photos. And then the Smile Makeover PDF ebook, as well as the Occlusion Design Team Training. We basically will send your team members, once you register them, access to a portal which only has that. They don't receive access to the whole thing like you do, but they do receive access to a portal that just has Occlusion Design Team Training. And you'll also be invited to join the Occlusion Design Facebook group. So let me just share with you these downloads. So if you go to the welcome section, so your Occlusion Design main course, welcome section, you have the before and after case photo package. These are the veneers. They're available as PNG or JPEGs. And then if you go and you just click to download them, and then if you go here, the Smile Makeover PDF book, you just click to download that as well. And these are designed to be used in your practice for basically internal marketing. They're not designed to be used externally. This PDF book is not designed to be printed. It's designed just to show on, say, an iPad or a computer. These JPEGs are designed to be printed. So these are designed to be printed. The PDF ebook is designed basically to show on a computer. So let me show you these. Yeah, this is one of the before and after JPEGs. So here's this one. That's this case. I have 3 versions of it. And lower veneers are really powerful in our practices. So one of them says, ask us about fixing your tooth wear. That gets people asking about this all the time. And then one of them is just the case, but I like the ask us about fixing your tooth wear the best. The other one is ask us about porcelain veneers. That one's not bad either. But I think the one that really I think is the most powerful is ask us about fixing your tooth wear. So you can print these, put them up in the walls of your practice, or show them on a device also, like an iPad or your office computers. And then there's this Smile Makeover PDF ebook. Again, this is something that you can scroll through and show patients on it's really good on an iPad, actually. I think that's the best application. So there's veneer cases. There's dental implant cases. There's porcelain crown and bridges. And there's some full mouth rehabilitation cases. So it's a nice little ebook just to show some different cases and help you with your case acceptance as you're kind of getting going with doing this kind of dentistry. Once we get rolling again, I have full confidence that once all of this blows over, we're going to be doing really, really well again because, there's always a need for this kind of dentistry. We might need to be able to phase some cases from an economics perspective,
That's where the phasing cases part of the full mouth rehabilitation case studies really will help us. And I'll be featuring that more on monthly webinars because I'll probably have to do some of that myself, more than I have had to do in the last few years. So we have to be able to adapt to the times. And part of me adapting to the times is offering this as a digital package without as high a investment. So I'm lowering the investment cost to try and make this accessible to more of you out there so that you can join and use this time productively. So one payment of $19.97, that's USD, or 3 payments of $6.95. So with $6.95, you can really get started with all of this. We have our monthly coaching webinars. We have a special series seminar coming up. I'm just waiting to announce the presenter once I confirm it. But I have a couple of offers out there, and we'll see which person we use as our first special series seminar. So again, use this time that we have now productively if you can. I think that this will be really helpful for all of us. This was my regular occlusion design membership fee. And we still have people joining at this fee even today, but I was just giving it a lot of thought last night. And I thought, to make this available to more people in this time of this COVID-19 pandemic, I just want to make it better, easier, more accessible to more of us dentists who are not in the practices right now and do have time to learn this material. So I've made it a different price point, price structure. We don't have to mail you anything with this, so that's kind of easier for us as well. It's all online delivery. And I think it's just going to make it easier for all of us that are having our practices closed for, who knows how long, 3 to 5, 6 weeks. And you'll be able to use this time productively. And I just want to contribute to all of your CE in an online environment because, again, we're not going to have any dental meetings for a little while. I was looking at something in the Globe and Mail, which is Canada's national newspaper, online, and they said that somebody got infected or went into the PDC, the Pacific Dental Congress, which is a huge dental meeting out in Vancouver, with COVID-19. And then they found that was the source person, 4 or 5 people within a couple of days who were also at that meeting ended up with COVID-19. And they've recommended everybody, 10 or 15,000 people that went to this meeting, to now self-isolate, which is pretty crazy. So I think we'll still have some small courses, maybe in a couple of months, some small in-person courses. But I think these big dental meetings might be done for the rest of 2020. So this is a good opportunity to take the time and learn online. And that's why I've tried to restructure this so it's more accessible to more of you all around the world. So hopefully you can take advantage of this. If not, I do have my YouTube channel with a few different videos on that. Nothing like what's available in the library of courses that I've put together, but it will give you some additional training. And if you can't do it, this week, hopefully at some point in the future, we can connect and you could join and we'll connect on our monthly coaching webinars and I'll be able to help you with pending cases you have thought about using and doing in your practice. So thank you very much. For this webinar, if you have any questions, if you want to type them in, let me know the questions that you have, and I'm going to create some new YouTube videos based on the questions. So I'll try and answer your questions through a YouTube video format. So I have my full studio to create YouTube videos here in the basement of my house. I'm at my house self-isolating, but I have lots of time to be productive. I'm going to create a whole new series of YouTube videos. So just let me know whatever questions you have, and I'll try and pick the most common questions and answer them with new YouTube videos in the next week even. I'll try and get onto these really quickly. So thank you very much for attending, and I hope this helped you. I hope you're able to join. If you can't join, that's cool. I totally understand. check out my YouTube videos, maybe some of my other free webinars, and hopefully we'll be able to connect with you being a member at some point in the future. So thank you very much, and we'll talk to you soon. Take care.
Hi, my name is Dr. Wayne Rux. I live in Austin, Texas, and practice in Lakeway, Texas, just outside town. I stumbled across Dr. Phelan's name on a website forum one day, and unlike most dentists, there were a bunch of dentists bragging on this guy, and I thought, well, if people are bragging on him, let's see what he's all about. So I went to his website, looked at his work, watched a few of the simple videos, got interested in it, checked on the Occlusion Design membership, and decided, I thought, it's too big an investment for me. But the more I thought about it, the more I considered, you know what? Let's do this thing and let's see if I can learn something from this guy. So I joined about 3.5 years ago. Went through the entire course, literally hundreds and hundreds of hours of continuing education on video. I got to thinking about how much money it saved me on travel and time, because I did almost every bit of this on my lunch hour. So I was using my time wisely and saving money at the same time. That occlusion design helped me develop not only a confidence to do the bigger cases, but even improved my daily bread and butter crown and bridge type work. When you're striving for excellence in a big case, it makes a small case seem really simple, and I found that really helped me a lot. That success with occlusion design inspired me this year to join Velocity Elite and see if I can improve my case acceptance and my marketing online, which I've been working on consistently. Still doing the videos at lunchtime and working on that a little bit every day. I can tell you that one tip from one of the webinars saved me $4,500. Just one tip alone, which is the cost of joining. So the more you think about it, the fewer reasons there are not to be a part of this thing. The other interesting thing the thing that I really enjoy are the monthly webinars. They're sort of like steady continuing education. So the things that you're learning through occlusion design and through Velocity Elite, then they're being reinforced in the monthly webinars. And I have watched plenty of webinars, and I always feel like people are trying to get in and get out. And trust me, if you've seen one of Steve's webinars, that is not the case. They go 2, 3, 4 plus hours. I don't know where he gets the energy to do it, but he does it, and so I enjoy it and learn a little bit every month steadily. So, like I said, it's been a great investment. If you ask me, I would just say simply, don't hesitate, do it, join. You're going to get more than your money's worth out of this thing, and when it's all over, you'll be a better dentist for it.
Hello, my name's Dr. George Olstein. I practice in Melbourne in Australia. It's certainly an easy task to give a testimonial for Stephen Phelan and his online seminars. I've been in the program for approximately 5 years now, and I certainly have learned a lot. And first of all, the seminars are logical, full of information. You can't go wrong, and it's taught me a hell of a lot. I also like the monthly webinars where Stephen goes through different cases that he does, and also answers lots of cases that others who subscribe present to him. His workmanship is just beyond beautiful. I'm always amazed how he can spend so much time, first of all doing the online seminars and then doing the webinars as well. I don't know how he gets time to spend with his family. But look, I've been a better person for the experience, and I highly recommend it. Do I have any regrets? Yes, I have one big regret, and that's the fact that I'm getting towards the end of my career, and I won't be able to... I'm disappointed that I didn't get onto Stephen and his program a lot earlier in my career. Thank you, Stephen, for everything that you've done for me, and as I said, highly recommend it to anyone that's contemplating.
So that's George from Australia. Really, really great person. Never met him in person. It's interesting. I've never met most of these people in person, but seeing the videos helps me. Like, I know all the names, but seeing the videos really helps me connect with these people, these members of mine, in a much better way. I think having the Facebook group will help build the connection too, because I'll see their little profile picture when I go in the group and answer questions and things. But, that's the one thing is being able to kind of meet people virtually through these testimonial videos has been really cool. It's been really good for me. I like seeing the members. Here's another person.
Hi, I'm Dr. John Tunison. I'm a dentist in Tuscany, Italy. I joined Stephen's online occlusion design course about a year ago. It has fully fulfilled all the expectations I had. And I find the teaching, the content, the presentations are fantastic. There are lots of tips and tricks. It's not all theory. It's mainly practical, mainly the real thing. The monthly webinars are an added bonus in that you have the possibility of presenting cases, which you can treatment plan together with Stephen, and follow that up monthly as you go along. The impact it had on my practice was quite amazing. I found that I had an increase in treatment acceptance, and the fact was that I felt more confident in doing the cases that before I was unsure of, and that is all thanks to the teaching I got from this course. So I highly recommend this course for anyone who wants to move up a level in dentistry and get even more enjoyment out of our wonderful profession. Thank you.
So that's awesome. Also, just, hearing that it increased his confidence to do these bigger cases is pretty neat. Here's another one of our members from the United States.
Hi, Dr. Joy Brower here from Phoenix, Arizona. Just giving a testimonial on occlusion design. Been a member for about 2 years now. Signed up, thought I'd get through the whole program in 1 year. Just didn't have enough time. So when it was time to renew, I renewed. The two things that I really like about occlusion design is that you're able to study whenever you have time. So I currently work about 4 to 5 days a week and then have 3 children. I'm always in the car at piano lessons or soccer practice after work. And so during that 45-minute or that hour, I'm able to log in on my phone and study and have a really productive time during that hour. And then also, second thing, I really like the ability to be able to see. I mean, it's like you're doing the dentistry yourself. You're able to see. I've taken probably $100,000 worth of CE over the last 15 years. And I would say this is the best dollar per dollar value as far as CE. Just the flexibility, the amount of content. It's just been an awesome program and I really have enjoyed it. Thank you.
So I that's pretty cool too. Just the ability to use your spare time as you're driving your children around, to be able to log into the site. I think that's cool. And the fact that she said this is the best dollar for dollar C she's spent in the last number of years is pretty neat too. Because I think it's a pretty good value for what you receive for that investment. It's a pretty small investment. If you look at the potential to add hundreds of thousands of dollars worth of dentistry to your productivity and the type of cases that you could do with this training, I think the investment's minuscule really for that. Anyway, here's another.
Hello, Stephen. Thank you very much for giving me the opportunity to say a few words about your flagship online program, Occlusion Design. Having participated in a myriad of hands-on courses over the last 20 years, I'm convinced that Occlusion Design is the best of its type by a country mile. The program is without peer for a structured, technically correct and foolproof system for aesthetic full mouth rehabilitation. Every aspect of patient assessment, case selection and treatment is covered in great detail and then some. The quality of the presentation, photography, videography is superb. The array of bonuses is mind-boggling. I can say this with some authority as I'm presently 2/3 of the way through my 3-year master's program in aesthetic dentistry at King's College, University of London. So I encourage my colleagues to stop procrastinating, stop sitting on the fence, and just subscribe. Thank you.
There you go. If you're sitting on the fence, we should just join and hopefully enjoy the program. So again, I'll run through a few more of these. I've got about 6 more that I've downloaded into this presentation. We have more on the site. We're adding more every day because I'm getting them Dropboxed to me every day. But for the course purposes of tonight, I'm going to show the next 6 and then I'm going to close it up. And if you'd like to receive this book, try and join while we're still here. I think it's worth it. Let's hear this.
Hi, I'm Dr. Bert Dan, and I practice with my son David in Tarzana, California. I've been with Dr. Phelan's occlusion design program for the past 2 years, and I have the highest respect and appreciation for his online teaching seminar, and also his clinical DVDs. The programming is logical and outstandingly lucid in video presentation, showing step-by-step procedures. Both my son and I have studied with some of the same mentors as Dr. Phelan, and we feel that Stephen's teaching is an excellent distillation of the best of the masters in aesthetic dentistry. I can unreservedly encourage you to further your careers by joining Stephen's mentorship. Good luck.
That's awesome. I like that. It was just fun. I really like that these are all just real iPhone videos, just real people iPhone videos. I just asked, just send me some videos, please. And I've got some really great videos. I think it's really cool. Here's another.
Hi, my name is Dr. Jessica Sismus. I'm a dentist from Miami. I've been practicing for over 13 years now. I love what I do, and I love learning more. And initially, I was looking for another course on, basically now I was looking for occlusion. I think the more experience you have, the more you realize how important occlusion is. And I was looking at courses, Dr. Spears, Dr. Dawson, and then I fell into Dr. Phelan's seminars, and I thought it was great because webinars really work for me in my schedule. And I couldn't believe what I learned. I really thought I was going to get into an occlusion course and just learn a little bit more about it, but really what I've learned is far more than I thought I would. He's developed systems, how to treat every patient. I now treat patients I never thought I would. My veneer cases are much easier for me now. I get way better results, much quicker, more predictable. Everything you can apply to any practice, really. I really recommend him. It's super affordable, and you could bring him anywhere. I bring him to the gym. I bring him to my couch. He's really like all the courses you can take online. I think he's an amazing talker. He talks very clear, very slow. You can rewind if you miss something. If your kids bother you, you miss something, you can always go back. You can go forward. I already done all the modules. I'm going through it again. It's stuff I really just want to learn off by heart. It's super valuable stuff. It'd be a shame. It is a shame that it's not taught in school, but it's something for everyone, and I highly recommend it. And I hope he comes to Miami. But even if he does, I don't know if my schedule will work. But if he does, I would love to see him in person. But he's just an amazing speaker. And I recommend this to anyone who wants to just better their career.
That was awesome. Lots of fun. She seems like a fun person. Here's another. If it works. Oh, that one didn't work. Some of these I had to take out because they didn't work. Oh, bummer. It didn't work. Let's see if this one worked. Something to do with this computer. It wasn't accepting all the videos.
My name is Dr. Lana Weibo. I'm a practicing dentist in Philadelphia area. I take hundreds of dental CE courses throughout the year, all over the country, just to stay up to date with all the recent technologies. And since I joined Occlusion Design course by Dr. Stephen Phelan, I cannot express enough how much value it carries. It has hundreds of hours of high definition videos under the microscope or so close up. That is just fascinating to watch them and hear Dr. Stephen Phelan commenting in the background. And being just a year out of dental school, I feel like I'm a totally different dentist since I took his course. And I keep learning from his videos, which I cannot even go through yet. There's so many of them. Another part which is great about this course is that Dr. Phelan hosts live webinars once a month that you have an opportunity to present your case ahead of time, and Dr. Phelan will review it and give you his honest opinion, his feedback, and practical thoughts. And I'm happy that I presented one of the cases, one of the most complex cases that I faced, and I got a great response from Dr. Phelan, and we had a great discussion. All of the videos online are super practical, that just being a new dentist, you can go to work next day and implement everything that is presented in the video, because everything is systematic, and Dr. Phelan is not using tons of products, but he's sticking with the best ones on the market that he feels comfortable working with, and that actually work great in my hands as well. So I'm very happy that I joined his Occlusion Design membership, and I'm looking forward to new videos every month. Thank you.
That's awesome. Awesome. Another young dentist. You know, it's nice to see the young dentists joining a program like this as well. Oh, she's right out of school, so we have to extend her membership, Jennifer. That's something we do if we know that somebody's right out of school.
Hello, my name is Spiro Cavalieratis. I've been practicing dentistry for 27 years in Johannesburg, South Africa. I have been following Dr. Phelan's Occlusion Design program and seminars for several years now. What I find most attractive is that I have access to his library of unique material that he has put together as a result of his countless monthly webinars over many years. I can do this in my own time, which is especially important as I live in a different time zone. This means that I would otherwise have to be watching them between 2 and 5 in the early hours of the morning. I love his logical, systemized approach to all his cases, no matter the complexity. He shares his material with clarity and enthusiasm. I feel privileged to be part of his membership program and to be able to benefit from his mentorship.
That's so nice. You can see we've got members all over the world. This works no matter where you are in the world. I have members from everywhere, from Mongolia to Taiwan to Singapore to Australia, New Zealand, to all over Europe, Russia, the UK, Ireland, even South America, Brazil, you know, even the Middle East, members all over the world, South Africa, obviously. It's pretty cool. It's pretty cool. Opportunity to connect with people all over the world is pretty